Mr. Minister, ladies and gentlemen, dear colleagues, I'd like to welcome all of you to this seminar on access to quality medicine and supply for sexual and reproductive health. This seminar is co-organized by two working groups of the platform Bigger Health and together with the DGP, so the Director General for Development Cooperation and Humanitarian Aid. We are also very grateful to Minister Kroll, Deputy Prime Minister, Minister of Development Cooperation, Digital Agenda, Telecom and Postal Services for honoring us with his presence at the opening of this seminar and for his commitment to keep high on the political agenda FRHR and access to quality pharmaceutical products. Mr. Minister, thank you very much for coming back here for the second time in 2 weeks' time for this timely and crucial message. Mr. Minister,
Thank you for the kind introduction. Welcome here. I would like to start with thanking Because Health and BTD for organizing this event, which is indeed about two topics that are on a personal level very close to my heart, but also at the center of our policy. One of them is sexual and reproductive health and rights. Everyone who follows a bit what we have done over the last years in our development policy knows that this is a very important topic in Belgium. A very important topic where we also have been able to rally a lot of like-minded countries around our ideas, together with the Netherlands, Sweden and Denmark with the She Decides action, which dates from March of this year. She Decides that continues to be a group of countries that find each other in advocacy, but also in mobilizing financing for this topic and in implementing certain projects. Since the She Decides conference, there has been a field trip in Benin and in Senegal on this topic. On any UN event, there is also a She Decides. There's always a She Decides side event where countries find each other and exchange on that topic. Second element, of course, is access to safe, effective, and affordable medicines. Kathleen, as you said, indeed, it's the second time in 2 weeks that I'm here. The previous event was one where Belgium was actually the first country to sign an agreement, a commitment, together with NGOs on quality of medicines. This is an initiative that has been followed closely by the World Health Organization, by the European Commission, and also by other European member states, because we are the first ones to really make a commitment on that topic. I think all of you know how important this is. In the poor countries of the world, approximately 1/4 of medicines is actually of very poor substandard quality. And especially in the domain of FRHR, we know that the needs are actually quite big, and that the access to quality medicines is not there at all. Besides that, and this is again in the She Decides perspective, we are doing a project with UNFPA on medicine supplies, and I would rather push this topic into the discussion which we will be having today. Very happy to see here also a big part of the participants from the private sector. As you know, the Sustainable Development Goals make the commitments between civil society, governments, but also the private sector as a core element of achieving the Sustainable Development Goals. And so in this topic of SRHR and access to quality medicines, we have made clear that this is important for us. We have taken a few steps in projects that we are doing, but we are here with a listening ear. Now, my listening ear is not going to be here until noon, because I have to leave, but I have brought a very good listening ear with me, who is Alan de Geet. Alan is following this topic in my cabinet, and Catherine is doing it on the level of the administration. I would love to hear policy recommendations on this domain. I think that most of you are on the practice side of this domain, also have views on what is happening in other countries in this topic. So I wish all of you a very lively discussion, but please crystallize that lively discussion into concrete recommendations that we could use in the years to come. So thank you for being here, and I wish you a great discussion today.
Starting our first keynote speaker. Brian McKenna is the Deputy Director of Reproductive Classified Coalition. In his role, he is responsible for managing the coalition's global action, and he also leads European donor and partner engagement. Prior to joining the coalition, he worked for 11 years for Population Services International in Zambia, Madagascar, and Washington, D.C. Brian McKenna will give an overview of challenges related to availability, equity, choice, and quality of reproductive health medicine and supply in the global health. Brian, you have the floor for 30 minutes.
Thank you very much. Good morning, everybody. It's a pleasure to be with you today. Thank you for the introduction. One of the things that wasn't mentioned that I thought about when putting this presentation together was that my first family planning presentation was more than 20 years ago when I lived in a small village in Guinea, West Africa, for 2 years as a Peace Corps volunteer. I used a flip chart with drawings of corn stalks evenly spaced to demonstrate the proper spacing of births. I'm not sure that the message went over so well because the local tradition held that the devil was white, so I don't think that the message got through quite well, and hopefully you'll see that my graph's been improved since then, and hopefully it won't be scary. And so the presentation today will go through just a quick overview of my organization, the Reproductive Health Supplies Coalition, and we'll delve into some of the many issues that pertain to reproductive health supplies, and then hopefully we'll have some time for questions. As I was saying, our secretariat is based here in Brussels. We also have coalition offices in Washington, D.C., Peru, Dakar, and Beijing. So the mission of the coalition, just again to familiarize you with it, is to bring together a diversity of partners and mobilize their collective strength to increase access to a full range of affordable, quality reproductive health supplies in low and middle income countries. And that's our website down at the bottom there. So you have a look. I'll be talking about a number of different topics and documents, all of which are available for reference on our website. Related to our mission, our vision is that all people are able to access and use affordable quality supplies, including a broad choice of contraceptive methods needed to ensure their better sexual and reproductive health. This would not be realized unless we can ensure that supplies are actually reaching those who need them, that they are affordable and within the reach of all, that they are trusted, effective, and safe, and that there is a sufficient range of products to meet user needs. These four broad preconditions, availability, equity, quality, and choice, form what we call the pillars of the coalition strategy. So, next. Okay. So many of the coalition's activities are led by member organizations through the medium of our working groups, regional fora, and caucuses, or implementing mechanisms, as we call them. These groups are the Advocacy and Accountability Working Group, System Strengthening Working Group, the Market Development Approaches Working Group, the Generic Manufacturers Caucus, the New and Underused Reproductive Health Technologies Caucus, the Maternal Health Supplies Caucus, and a French-speaking regional forum called Sécurité Contraceptive en Afrique francophone, or SECONAF, and the Spanish-speaking regional forum, or FOROLAC, for members of Latin America and the Caribbean region. Other activities of the coalition are led by coalition secretariat members themselves, but all of our activities employ approaches that we have come to recognize as our levers of change. The unique attributes we bring to bear to achieve results: our neutrality, our convening power, our ability to broker partnerships, our brain trust, the flexibility afforded by our broad resource base, and our respected name. By applying these levers of change, the coalition ensures that the reproductive health supplies reach those who need them, that they're affordable, that they're trusted, effective, and safe, and that there are sufficient range of products to meet user needs. So that's the Reproductive Health Supplies Coalition. Certainly be willing to answer any questions about that as we go, but I am now going to delve into some of the issues in reproductive health supplies. So I'll start with the most important slide possibly. We're all working for her, this woman standing across the counter. Evidence demonstrates that reproductive health programs empower women, reduce pregnancy-related health risks, create positive impacts on the environment and economic development, in addition to many other benefits. As she decides, rightly says, every girl and woman has the right to do what she chooses with her body, and she has the right to health. And these rights affect her personal development, her participation in society, her livelihood, and whether her family and community thrives. But what would she do without access to the reproductive health supplies to which she has the right? A doctor can give advice, but if the products are not available, what is she left to do? When it comes to reproductive health supplies in the global south, we see some of the world's greatest successes, but also troubling statistics and seemingly intractable challenges. For example, in Francophone Africa, while Senegalese women today are reaping the benefits of a joint distribution venture among government, private sector, and civil society called Yaxina, women in many other countries face difficult, potentially life-altering choices caused by stockouts. Trained community health workers in Burkina Faso traverse the country's vast rural areas, delivering one of the newest and most promising innovations in the field, a subcutaneous injectable. While other countries in the region, women face limited choice and even more limited access. But there's one thing and all these countries have in common: a woman's desire to ensure her reproductive health. So much in a woman's life can hinge on the response she gets when she arrives at the clinic or pharmacy. So much goes into making sure that the response she receives is the right one. Will she receive choice or empty shelves? The next. Access to contraception is not only a woman's right, it is a sound financial and economic investment. For example, in its January 24, 2015 issue, The Economist, referencing the work of the Copenhagen Consensus Center, reported that ensuring access to contraceptives is one of the best investments in development, rendering $120 in benefit for every dollar spent. So if it provides such a solid return on investment, one might assume that there would be no problem with funding. Even as family planning programs are expanding, contraceptive supply shortfalls threaten to stall progress or reverse recent gains in many countries. Our community has developed the capacity to triage urgent supply shortages through mechanisms like the Coordinated Supplies Planning Group, which seeks to improve supply chain coordination for family planning commodities through continuous collaborative development of forecasts and supply plans amongst the major donors and countries they support. In 2016, the coalition decided to take a longer-term approach. We asked, can we predict the volume of supplies users must consume early enough for decision makers, funders, manufacturers, and advocates to work together to ensure contraceptive security? Can we project costs far enough in advance to prevent funding gaps from occurring? This is the impetus for the 2015 Global Contraceptive Commodity Gap Analysis, which may be found on our website that I mentioned earlier. The analysis includes calculations of users of contraception and consumption costs of these supplies to determine the funding gap based on two scenarios. One here in green is if current trajectories continue. In yellow, or I guess orange, this is the scenario in which the FB 2020 goal of 120 million new users of contraception is reached. So if you take the projected cost of supplies in 2020 under scenario A on the bottom, the top is all 135 low and middle income countries. On the bottom, 59 FB 2020 focus countries. If you take the projected cost of supplies in 2020 under scenario A, that means current trajectories are maintained, which is $1 billion, shown in the green box. You subtract the current level of spending, that's nearly $822 million. The difference, $233 billion, is the gap. That's if current trajectories continue. If we were to reach the FB 2020 objective, that number raises almost by double to 437 million. And this is the gap for 2020 alone. 2017, 18, and 19 have their own multi-million-dollar gaps. The gap is based on the assumption that spending on supplies will not increase above the most recent measurable level. Last year, level funding was our worst case scenario. We call this worst case scenario because it meant that every additional user of contraception added after 2016 would have to self-fund per supply purchases. This raises serious questions about equity and the expansion of access to family planning. This year, we face the prospect of a worst-case scenario or a new worst-case scenario, one in which funding for supplies actually decreases. The 2017 CHI Family Planning Market Report, which we'll look at next, shows that there has been actually a decline in donor spending on supplies across the 69 FB 2020 countries. The change in political leadership in the United States has put millions of dollars of funding in jeopardy, as I think we all know. We must now consider not only whether additional users of contraception can pay for their own supplies, but also whether users who currently obtain supplies from the public sector have the capacity to absorb new costs. One finding from the commodity gap analysis in 2016 was that many found surprising that across 69 lowest income countries, we attributed the majority of spending on supplies, that is 54%, to the private sector compared to 46% in the public sector. This finding raised the question of how much we really know about out-of-pocket spending by users of contraception who obtain their supplies through commercial channels. To explore this critical issue, the next commodity gap analysis that will be out next year will bring new visibility to private sector supply costs and OOP spending. Next, please. So as I was mentioning, the 2017 Family Planning Market Report was just released. And we know that the family planning community continues to face funding challenges and uncertainty. The future of FB funding, or the funding in the commodity market, may be under threat. So the analysis from this report, released this week and produced by CHI with the support of the coalition, has revealed a sharp market value decline of 28% from 2015 to 2016 in the public and social sectors in 69 focus countries, after remaining relatively stable since 2011. The report suggests that the value decrease was caused by substantial decline in shipment volumes, particularly among injectables and oral contraceptive pills, combined and progesterone only, and was not attributed to any price changes. While the shift toward long-acting methods driven by growth of implants helped offset some of the declines and implied a couple years of protection shift, it is still the lowest market has seen in 6 years. Further, the donor-funded market, analyzed in a subset of the public and social sector market, has seen a corresponding decline in donor-funded shipments in 2015 to 16. The report hypothesizes several potential reasons to explain the value decline in 2015 to 16, including volume shifting towards local and regional suppliers, not participating in the report, and procurement pattern fluctuation. However, the concern is that a third possibility is in play. The decline in donor spending implied by decreased donor-funded shipments may have led to the decline in total public sector procurement, where governments and other procurers do not sufficiently cover the shortfall, potentially impacting the number of users of modern contraception. One other issue that we see in our community and reproductive health supplies is that of data visibility and analytics. As a community, our ability to tap different data resources, deliver timely data, and take quick decisions is becoming increasingly constrained. Why? The diversity and siloed nature of data platforms makes triangulation of information inefficient and hugely time-consuming. Different software systems, hard soft copy, etc. Outdated IT systems mean that tools have outgrown and outdated their platforms. The cumbersome nature of some data collection tools is becoming a barrier to expansion and growth. Growing proprietorship over data sources and even existing data hubs means that visibility is hugely constrained. Visibility into procurement and quantification reports are limited to certain organizations, and access to the certain tools is restricted to licenses. At the end of the day, however, the implications of this reality are threefold. Donors are less able to undertake coordinated decision-making for making the timing of procurement and delivery of adequate quantities difficult. Countries are less able to take action when products arrive and advocate if funding falls short. Our community has less visibility into data across the supply chain from manufacturers to country, and country-level inventory and demanded data, making it harder to forecast and make critical decisions about entering markets. One approach to tackle this issue at the global level is being led by the Coalition. With funding from Gates and DFID, the Coalition is leading an initiative known as the Global Visibility Analytics Network, or VAN, a virtual collaborative space where teams use the same data to make supply chain decisions. The global VAN would allow multiple people to simultaneously access the same data and technology to talk to each other and make decisions together about when and how to get the right products to the right people at the right time. One of the other issues that we are approaching at the Coalition and within the community of reproductive health supplies is that of youth and reproductive health supplies. We know that young women face a significantly higher burden of unmet need for contraception than older women do. A Gudemacher report on 31 developing countries indicates that women between the ages of 15 and 24 face an unmet need of 31% compared to only 23% when women are between 25 and 49 years old. There are multiple reasons for this gap, situated under the 4 pillars identified by the Coalition that I mentioned earlier: availability, quality, equity, and choice. So why is this situation, or why do we face this situation? Financial dependence for out-of-pocket payments, stigma surrounding premarital sex and provider bias towards young people, age-based restrictions on accessing reproductive health supplies, lack of quality contraceptive, sexual education. In addressing these barriers young people face when it comes to access and use of affordable quality health supplies, including a broad choice of contraception methods, are vital to bridge the gap and work towards reaching universal health coverage goals. So what does the Coalition do? We work to develop policy recommendations to tackle the barriers young people face, work on capacity building of youth-led organizations, and provide small grant funding through our Innovation Fund rounds that focus on youth and reproductive health supplies. On the Innovation Fund, just a little word on that, it's managed by the Coalition Secretariat. It is the Coalition's flagship initiative for inspiring and financing new activities that further the Coalition's strategic goals and those of its implementing mechanisms. We do a number of those with youth organizations, including a couple of examples: a new mobile phone application called Donde, which helps young Argentinians typically locate nearby reproductive health supplies and services, and another one in China, actually being implemented by MSI, and they've put together China's first guidelines for assisting service providers increasing young people's access to full range of contraception, which have been piloted in 6 hospitals prior to a national scale-up. Maternal health and safe abortion are also important issues within this space. Globally, 2 leading causes of maternal mortality are postpartum hemorrhage and preeclampsia or eclampsia, together comprising 40% of all maternal deaths. Fortunately, treatments exist for combating these conditions. Oxytocin and misoprostol are both used to prevent and treat PPH, while magnesium sulfate is the most effective agent for treating seizures associated with preeclampsia and eclampsia. Although all life-saving commodities are important, these 3 maternal health supplies are often essential during emergency circumstances. As such, increasing the availability, affordability, and quality of these maternal health supplies is critical to reduce pregnancy-related deaths. Ensuring access to safe and affordable maternal health supplies has been an ongoing priority for the coalition, where they too are reproductive health supplies. It has led to the establishment of a distinct community of practice known as the Maternal Health Supplies Caucus, which I mentioned earlier. It has inspired our active engagement with at least 2 technical resource teams, the UN Commission on Life-Saving Commodities. And with the winding down of the Commission activities last year, the Maternal Health TRT was joined with the Maternal Health Supplies Coalition in order to continue and build upon the work of both groups. In safe abortion, from 2010 to 2014, we know that an estimated 56 million induced abortions occurred each year worldwide. This number represents an increase from 50 million annually during 1990 to 94, mainly because of population growth. Most women undergoing abortion do so because they become pregnant when they did not intend to, and 84% of unintended pregnancies in developing countries occur among women who have an unmet need for modern contraception. However, it is not only about access, but about having access to using the method best suited, thus reducing contraceptive failure rates. Avoiding unintended pregnancies is important, not in the least because in many countries, abortion is not legally available. Almost all abortion-related deaths occur in developing countries, with the highest number occurring in Africa. Recent studies estimate that between 8 and 18% of maternal deaths worldwide are due to unsafe abortion. And the number of abortion-related deaths in 2014 ranged from 22,000 to 44,000. So what does the coalition do to address this? The issue of safe abortion has never been absent from the coalition's work or discourse. For many years, the coalition's caucus on new and underutilized reproductive health technologies, or NERT, has published technical briefs devoted to both manual vacuum aspiration, mifepristone, and misoprostol for medical abortion. The Maternal Health Supplies Caucus has always included misoprostol among its list of priority commodities. At the Reproductive Health Supply Coalition's 16th General Membership meeting in Oslo 2 years ago, participants highlighted the connection between supplies and safe abortion as an issue worthy of further pursuit. And acting upon that recommendation, the Norwegian Agency for Development Cooperation, or NORAD, supported 4 Innovation Fund grants on safe abortion supplies in Asia, Sub-Saharan Africa, and Latin America. In order to continue its work on this issue, the coalition recently created a new safe abortion workstream within the NERD caucus. Specific examples of the coalition's Innovation Fund supported work in this area of safe abortion include a mobile health app for healthcare providers to better track medical abortion and FDA supplies on their premises, thereby reducing the frequency of stockouts, and an analysis of the barriers to registering misoprostol and mifepristone for safe abortion in Latin America. Results show that professional health association support and prior registration for obstetric use were positively associated with securing national regulatory approval. So with that, I'll leave it to open to questions, assuming that we have enough time. If not, we can do those later. One thing I would like to mention, though, is that I have not mentioned is the issue of product quality and registration. Obviously an important issue, but I have left it out because I assume that my colleague from WHO is going to be covering that. So I just wanted to mention that. So I'll be happy to take it. Thank you.
Thank you very much. We have some minutes for some questions. Some questions for clarification.
First of all, thank you very much for your work. My question is actually, how can you ensure the long-term sustainability of the work? For example, if now you could sponsor money and buy products from some German company, that's great because you can provide access and quality medication. However, in 10 years, you will keep coming in a way the German company, and in 10 years, you will have a good running company in Germany. And in 10 years, the people on the spots will still be relying on the same company in Germany, needing still sponsor money in 10 years, in 20 years, in 30 years, etc. So my question is then, how do you ensure this long-term sustainability as well while providing access to quality medication? Thank you. Did you understand the question? Yes, I think so. Thank you. Should I answer that or should we? Okay. Well, at the coalition, I guess I should clarify, does not provide financing to the pharmaceutical companies. As a member organization, we are a member-centric organization that includes private sector organizations in addition to civil society, donor and government organizations. We would certainly hope that companies such as the one in your example, German pharmaceutical company, would work with the community to ensure that prices are affordable, so that products are available and that they're of high quality. And how we would ensure that that is sustainable is a question not just for the coalition but for the community. I would say that we will probably hear a little bit more from our colleagues from UNFPA on how we might start looking differently at how we finance sexual and reproductive health and rights, and particular supplies in the global south, and that we might see a shift in domestic and versus international resource mobilization. With a decreasing amount of money coming into countries from international sources, as I mentioned earlier, the burden is going to be more squarely on governments and citizens, users of these products in the global south. And I think it's beholden upon us to find a way to make sure that those who need those products but can't afford them can access them at the public sector level. But those that can afford them and can pay a smaller price can access them through other channels, including subsidized social marketing channels. And those who can pay for them can access them in the private sector markets. I hope that helps to answer your question.
Thank you. Are there any other questions?
Thank you very much for your presentation. I actually have a question. Yes, I am Adriana Lozada. I work in the program of the European Parliamentarian Forum on Population and Development. I actually found very interesting the presentation. Thank you very much for some examples of the Innovation Fund mechanism. I actually have a question for funding that you mentioned. Can you just clarify again the difference between the green and the orange? And also, is it possible to find the per country gap in somewhere online?
Yeah.
Thank you.
There were also one or two other questions that you can.
Hi, good morning. My name is Caroline. I'm a student. My question is mainly about how do you work with capacity building, specifically with the student organizations, as you mentioned. Are these locally within countries, so for example, the Global South, or internationally, do you work more with NGOs? So it would be more specifically about your cooperation with youth organizations. Thank you.
I can take that question as I run the youth caucus. The fact that we are a member organization means that all types of members can apply, so that can be a young, that can be, we have member organizations that have like only 4 people in a small rural area in Tanzania that go door to door with condoms, or you have bigger youth alliances with that are themselves member organizations, youth-led organizations that are a member. And in our youth caucus, all these different types of organizations gather as a monthly basis to talk about topics they find important and try to discuss different approaches to the problems they face at different organizations. So the types of organizations we work with kind of depends on the organizations that become a member of our association and that work with us. So that yeah, we have all types of different youth-led organizations, from small to big, or youth-led organizations, or youth champions from bigger international organizations as well. So yeah, we have a very big variety of different types of youth-led organizations. Thanks. And the other question, gives me a great opportunity actually to mention that we just last week released a new call for concept notes for our new innovation fund round. So, and there are actually recipients of past rounds around the table today. So it's available to not only organizations situated in the global south, but international organizations as well. So that's just something I am happy to mention. Thank you for the opportunity. You also asked a question about the funding gap. As I said, all of this information, including the commodity gap analysis, the FE market report, all of this is available on our website, and I can certainly direct you to that. One of the other things that's on the website is a tool that will allow you to customize your question related to the funding gap. For example, you could choose just to look at the 69 FP 2020 countries. You could choose to look at just countries in Francophone Africa, Southern Africa, South America, whatever you were interested in doing. And to answer your question about the yellow or orange and green, the 2 different scenarios are projections based on I think it was trying to remember the colors, but the first is the lower estimation is the assumption that current trajectories continue, that we would continue on our current path without any kind of drastic decrease or increase in the use of contraception. The other is if we were to meet the ambitious FP 2020 goals of 120 million users by 2020, which I think is an ambitious prospect, but it just obviously increases the gap. I hope that answers your question.
Okay, thank you. Maybe we can go now to our second keynote speaker. It's Reproductive. He joined the WHO in 2009. He's working within the regulatory system strengthening team, and he's responsible for provision of technical assistance, capacity building for quality control laboratory, manufacturers of pharmaceutical products, and national medicines regulatory authorities. Prior to joining the WHO, Rutendo worked as a senior manager with the Medicine Control Authority of Zimbabwe for 15 years. Rutendo will present the results of the WHO survey of the quality of medicines identified by the United Nations Commission on Life-Saving Commodities for Women and Children.
Thank you, and good morning to everybody. I'm glad to be here to make this presentation. I've been a regulator for over 25 years now, so if you might excuse my bias towards the regulators that are for and against them. So my question was to present on the outcomes of the survey that we conducted a few years ago on behalf of the Commission. But in the process, I have decided that I will talk about other activities or surveys that we have been engaged in as WHO for evaluating the quality of reproductive health products. In my presentation, I'll also use the example of oxytocin injection, which I think is instructive for us to see how we have been performing as partners and regulators. So our evidence in determining the quality status of reproductive health commodities is from several sources. We look at other studies which have been developed and we determine, and on that basis we come up with our own assessment of the quality. We also do our own studies, and I will be sampling some of the studies that we have recently conducted, and also we collaborate with partners like the UN Commission on Life-Saving Commodities. So one of the ways that we do is we do some systematic studies, and we did one. There's a publication in the British Journal of Obstetrics and Gynecology. So this was a systematic review on the quality of oxytocin. The objective was to identify critical assays and synthesize the findings of studies which have been published over time. So we looked at 7 databases up to 2015, and the most important thing was to look at the oxytocin, the quality or assay, as we call it, the quantification of the oxytocin, and also the other quality, important quality attributes, which is validity. So starting from a total of over 3,100 studies or publications, we came up finally with 8 studies, which involved 559 samples of oxytocin that were sampled and tested in 15 countries. And the sampling was obviously done at facility level at the treatment site. All in all, the most important thing that came out of the study was that 1 in every 3 women would receive less oxytocin than expected. So this was 30%. At the time, there were very few, or from the studies, there were very few products which were of assured quality. I'm also representing the WHO pre-qualification project or team. And at that time, up to 2015, there were no pre-qualified products. Today, we only have 2 oxytocin products that are pre-qualified. In most instances, the suppliers of the oxytocin were not registered, or the good manufacturing practice status was not assured or not verified. Also, the studies demonstrated that the issue of quality could not be ascribed to the manufacturer or the supply chain. So what we have done is within the pre-qualification program within WHO, we also engage in activities where we monitor the quality of several products, including reproductive health products which are on the market. The focus is on those products that are pre-qualified, because once we pre-qualify a product, we would like to follow the product on the market and see the quality status of those products. We also take advantage of this situation and look at other products which are not pre-qualified but are within the same grouping to evaluate the quality of those products. In addition, we would also like to contribute to the capacity building of the regulatory authorities where the products are being distributed. So as mentioned, we participated as a partner, as a technical partner for the Commission, where they have identified 18 neglected commodities for women and children. So we identified these products, and then we went out onto the market to evaluate these products. First thing was to look at which products were of good quality that were available on the market, and in addition, if there were any products that were not of assured quality, we would also evaluate how much effort would be required for those products to actually meet attributes. Also, we looked at of course, there are 39 countries which were in the project, but 22 countries qualified to be included in the survey. But at the end of the day, we ended up with 10 countries, and that's the list of countries. So the criteria for including those 10 countries was essentially that these countries must have in their marketing authorization registers some of these products which the Commission was interested in. In addition, it should not be only one supplier or one manufacturer, it should be several manufacturers. We also expected that the regulators had some experience in regulating the product. We also tried to have a wider distribution, geographical distribution of the countries, and most importantly, the national medicine regulatory authorities has to be willing to cooperate and participate in the studies, because the regulatory authorities are the ones which actually go out and sample the products from the market or from the treatment site. So this is just the geographical distribution of the countries that we were looking at. We did focus mostly on the African continent. So when we had the countries, we then looked at the products and made some decisions on which products we are going to target for the sampling. Most importantly is not to target products where there was some assurance of quality. So those products that are supplied from a country which was considered to employ stringent regulatory requirements or systems, we did not target those products. So whenever they were seen on the market, they would not be sampled. We also looked at some of the products on the basis of stability, of issues with production. So those products which are low risk for manufacturing and formulation were also excluded from the list. And of course, we did not target products that were from the innovator companies. So this is the list of products that we finally ended up looking at from the country. There were different sites, for example, for the oxytocin in the 5 international units and the 10 international units, magnesium sulfate injection, gentamicin injection, protein benzoyl penicillin, the various strengths, penicillin injection, ceftriaxone injection, betamethasone injection, the 2 forms, whether the phosphate or the acetate. Amoxicillin as the dispensable tablet for pediatric use. Zinc sulfate, either as the dispensable tablet or syrup for pediatric use as well. Levonorgestrel tablets, the 2 strengths, 0.75 and 1.5 milligram, and mifepristone tablet. So we managed to collect 205 samples, and the results are the green part is 155 of 205 samples met the test requirement, and 47 actually did not meet the requirements. So this is the distribution of the products, where you have the bottom or green part are the products that were compliant, and the yellow part, the top part is the component of products that did not meet the requirement. Oxytocin, which is the first one, out of the 22 products or samples that we found on the market, 14 of them did not comply with the requirements. And I will come back to oxytocin. You will see a general trend, but it looks like the oral formulations of the solid dosage forms have less problems. Injectables might be having problems. A little bit of a surprise, we expected that the quality of the antibiotics would be not so good as well, but this was not the case. A zinc sulfate tablet, which is for diarrhea in children, all the 21 products that were sampled were found to be meeting the expected quality attributes. So I will look at the oxytocin injection in particular and the lessons that we learned from there. We have the report which is published. It is on the website. Printed copies are also available, so if anyone wants any printed copies, you can give me your details and we can send it to you. So samples were collected from the central store, so this was not at the treatment site. So at the time of sampling, we also evaluated the temperature under which the product, or the storage conditions under which the products were in the stores, at the central stores. And also we looked at product level information. For example, what was the quality standard that the manufacturer was declaring on their level? We also evaluated whether they mentioned the adequate storage conditions for the product and other quality declarations that the product must have. We also evaluated who the manufacturer declared on the label was. So if you look at the failures by country, if you look at the 22 samples, Burkina Faso, for example, of the 2 samples that were picked in the country, one of them was meet requirements, and then in brackets you have the source country. So you will see that invariably all the products that were failing in those countries were coming from either China or India, and they could be from different manufacturers. Zimbabwe is a particular case because, interestingly, the 2 products that were found in that country were not registered by the regulatory authority, but they met the requirements. And I'll come back to an explanation as to why that happened. So the failure rate was 64%, which was very worrying for us. So, of course, the products were coming from many different manufacturers. So in order to be able to compare the products or to have a common testing parameter, we tested them on the basis of one reference standard. And in this case, we use the International Pharmacopoeia. So when you look at the International Pharmacopoeia, which is published by WHO, for 18 of the non-compliant products, the content of oxytocin was less than the expected minimum of 90%. The worst case scenario was where the amount of oxytocin was 50%, around 50% of what it was supposed to be. And the best failure was 89.98%, which is just below the minimum expected. However, when you look at the results for the assay or the quantity of the oxytocin, it was always related to a significant level of impurities, which suggested that there could be degradation or instability of the product that we were testing. In one specific product, there were particles inside the vial or the alkyls that were visible to the naked eye. Of the other 6 products, although the amount of oxytocin was within the expected limit, there was an unacceptably high level of impurities. So they were all above the acceptance limit. So one way we also looked at the registration status. We interviewed some of the regulators to find out exactly how they actually register the products. Did realize that when you look at the registration status or the claims by the manufacturers, that the products were supplied or registered on the basis of different references, either United States Pharmacopoeia, British Pharmacopoeia, Vietnamese Pharmacopoeia, Chinese Pharmacopoeia, and in some instances the products were being supplied on the manufacturer's own in-house specifications. So this has impact on interpretation of the results going forward, because we were referring to the WHO published International Pharmacopoeia. And if another pharmacopoeia is used by the manufacturer as a reference, it might mean that we have different interpretations of the quality attributes of that product. Some manufacturers had their products registered in the countries, and they were approved by the regulatory authorities on the basis of the in-house specification. So there was never a comparison with the recognized pharmacopoeias to see how best these in-house specifications be applicable for the product. The other thing, which concerns me particularly as a regulator, is it's a general practice that if you have an injectable formulation, which is only going to be used once, or this is single dose or single use, there is absolutely no reason why you should have a preservative. Preservative also includes other issues where the product is going to be, maybe it could be introduced intrathecally, might have problems with that. But you did find that some of the products actually had a preservative. And I'll come back to that. There was no justification provided to the regulators or adequate justification provided. In some instances, for example, where the product was manufactured and we found the visible particles, it was pointing to a manufacturing problem. And in some instances, going back to the issue of the preservatives, manufacturers will include a preservative in their product just in case, because it's supposed to be a sterile product, just in case during manufacturing something could go wrong. So they are covering up for their lack of good practice by including a preservative, which makes the situation worse for the patient. Storage conditions and shelf life for the products are assigned by the regulatory authorities on the basis of data which is supplied with the product. So a regulator does not decide that for all the oxytocin products are going to have the same shelf life or are going to have the same storage conditions. It is actually on a case-by-case basis. So you will find that different products from different manufacturers will have recommendations for storage under different conditions, and shelf life could vary from country to country, sometimes even for the same product. So effectively what we noticed was the quality of oxytocin in lower and middle income countries was questionable. The cause of the low quality could be the supply chain, this is the storage conditions, it potentially could be the manufacturers, and also it could be the regulators with inadequate regulatory oversight. So looking at the oxytocin case, we tried to evaluate what would be the reason for the failures of the product. Of course, it could be the storage conditions. Some of the products were stored under room temperature when the product recommendation was it should be stored in the fridge. The reference pharmacopoeia was not declared. Some of the manufacturers, remember I said we looked at the labels, we did not declare the quality standard which the product was to be evaluated against. So therefore, a manufacturer or anybody who would be testing the product will be referring to a different pharmacopoeia or wrong in terms of the manufacturer. Some manufacturers will decide to use a certain pharmacopoeia because it has less stringent requirements. So the choice of the pharmacopoeia, so they decide, okay, this one has less requirements. And I'll come back to this. The International Pharmacopoeia is the only pharmacopoeia, well, it's one of the two pharmacopoeias which refers to or mentions the specifications or the requirements for testing for impurities. All the other pharmacopoeias do not mention this. So therefore, what it means is the manufacturer might decide to refer to a pharmacopoeia which does not have requirements for impurities in the product. As you can see from the result, that nearly all the products that we tested have issues with the impurities or degradants. Poor manufacturing practice, where the manufacturers are not familiar with their product. Poor formulation. And this again comes to the issue of the preservative. The innovator product contains a preservative. So most of the generic manufacturers included a preservative only because the innovator included a preservative. And in our results, we are able to actually see, and I think the NFPA can attest to this, that in some studies it has been known that some of the preservatives actually have issues on the stability of the product. So copying the innovator is not always the best solution. The manufacturer must know the current science with regards to the formulation. In most of the pharmacopoeias, it's mentioned that oxytocin is affected by that. So a simple thing, manufacturers should make sure that they amber colored, or maybe the product, the packaging as a protected product from light. So when we had these results, we decided to do another follow-up with the regulators to see if we could ascribe the blame on the regulators not doing enough. So we looked at the performance. We sent out the questionnaire to the regulators. 8 countries with failing samples. Unfortunately, only 3 answered the survey. But when we scored them, they did very well. So we were not sure how is it then possible that you have products of low quality in the market when the regulatory authority is scoring so well. So we were not sure where exactly the system failed. We also looked at 3 of the products from the 22, and this is the case of Zimbabwe, where the products were not registered in the country of collection. They had been introduced into the country on the basis of it was a donation, but the most important thing was that they control the donations. They have a procedure in which the quality of the donations is in place. They only accept products. They have certain criteria, quality assurance systems in place to make sure that even though the product is not registered, the quality was assured. And this is one mechanism which we found to be used in other products outside the reproductive health arena. We also did another study, and I attribute to my colleagues again in the WHO. We decided to look at the stability of oxytocin along the supply chain. So this is published in the Science Direct. Next slide. So what we did was we followed oxytocin injection from the manufacturer, which is based in Europe, up to Accra, Ghana, where the product was going to be distributed in the country. So as far as we know, this was the first study that evaluates the extent of temperature exposure impact along the supply chain on the quality of oxytocin from the manufacturer up to the service level. So this is what it looks like. So the first part is when so we put in data logger, so we monitor the temperature from when the product was released by the manufacturer up to the end, the user level. So you can see in the first part, the product left the country, Germany, and was shipped to Accra. There was essentially not much fluctuation in terms of temperature. Temperature is supposed to be, the product is supposed to be stored between 2 to 8 degrees Celsius. And what you find is the average should be around 5. So 2 to 8, the average should be around 5. So when the product arrived in Accra, the first month, the product was stored in the central stores. And as you can see, which is the second column where you have the darker portion, everything was around 5. Some fluctuations in temperature to about 10 were noted. So these actually data loggers were with the product. So it was part of the packaging, and this was recorded, was recording on a day-to-day basis all the time. And then the products were distributed to the regions, to the regional stores, and you can see then things started happening. You have temperatures which are going way, way above the 8 degrees Celsius, and the situation was even more chaotic at the service level. So there was more activity there. So the product, this is oxytocin, was actually not being stored according to the expected conditions. So the lowest temperature was minus 9 degrees Celsius, and remember the product is supposed to be stored as 2 plus 2 degrees Celsius. So it was minus 9 below freezing. And the highest was room temperature for some of us, 30 degrees Celsius. However, when we tested the product, none of the products failed. So we tested the product before it left the company. We tested the product after the 2 to 3 month journey up to the service level. So there was no failure for the product. So this was a product of good quality. So it brings the question, I'm sure if I go around the table and ask you, how should oxytocin be kept? Most of you will say it should be in the fridge. But this data seems to suggest that you don't necessarily need to put it in the fridge. So we need more data. We need more data to substantiate this claim, whether this applies to this specific product or it affects all the oxytocin. I have a theory, for example, when you compare this to the other products that we looked at in the other study, that it has to do with the formulation. This product does not have a preservative. Some of the products that we're selling have a specific preservative which actually affects the quality or the stability of the product. So the study actually demonstrates that we need to routinely monitor the oxytocins that are available on the market. I have a few recommendations with regards to the national procurement systems, and this is coming out from the survey as well. So when we look at the country, 71% of the countries actually mentioned that they had national coordination mechanisms for medicine procurement. However, there was not always a coordinated demand aggregation, establishment of shared market information and market controls. There were different suppliers of products in the market, and procurement policies were not always the same. We know for some manufacturers, no matter how well the regulatory authorities perform it, if there is more than one door in entering the market, they will use it. So there is need for quality assurance systems that are aligned between the different procurement agencies. There was mention of logistics management information systems by Brian. Actually, we noticed that in most of the countries, they had electronic systems, but they were only at the central level. And as you go further down the supply chain, it was all paper-based, and therefore there was very little or poor information sharing between them. Only 35% of the countries that participated in the survey actually promote local production. So they give tax incentives for producing products locally and hopefully of local quality. However, 76% of them actually provided incentives for importation of medicine. So there is a need for tax incentives, particularly for local production. And this again for us goes to the issue of sustainability of good quality products. So tax incentives could be used. For manufacturers, as I mentioned earlier, manufacturers will always use the easier quality route. So manufacturers should be encouraged to know their product and use the pharmacopoeia at the basic minimum. And then on the basis of their knowledge of the product and the science that is available, use the appropriate quality standards. As we know that in the reproductive health sector, I understand that it's not really a profitable business for most of the manufacturers, but the regulators still have high demands. So meeting the regulatory demands means that the manufacturers of the products need to generate a lot of data. So I'm urging researchers to actually help some of the manufacturers by generating some of the data, whether oxytocin needs special storage requirements, whether there are stability issues with some of the products, the different quality attributes, what are the degradation pathways, for example, for oxytocin and some of these products, because a lot of the generic manufacturers do not have the basis in science to be able to provide this information. And one of the major issues in pre-qualification for the oral dosage forms for reproductive health is the requirement for what we call bioequivalent studies. It costs between 100,000 and 600,000 in one study. So some of the manufacturers cannot afford this. And the only thing that is required is for some peer-reviewed evidence to demonstrate that bioequivalence is not required. The regulators cannot generate this data, but it is only the researchers. So we are talking about providing evidence that some of the reproductive health products can actually qualify for biowaivers and reduce the regulatory burden on the manufacturers. Of course, I did not have the time to look at the different pharmacopoeia, but I would urge producers of pharmacopoeia to make sure that as much as possible they align their quality attributes. Regulatory systems, 56% of the regulatory authorities that we evaluated as part of the survey actually did not have favorable regulatory control or oversight. There is need for capacity building, training on the regulatory authorities on dossier review, not to accept manufacturers' claims for quality on face value, but to be actually able to look at this in greater depth. The other thing is to also for the regulators to start working together, joint inspections and joint product reviews, particularly for products that are going to be submitted to the various countries. We have existing initiatives within WHO that actually regulatory authorities can participate in. There is also the need for regulatory authorities. Some of the products were actually supplied in the countries without registration because registration was taking a long time, even though the products were coming from sources of assured quality. So we in WHO are encouraging manufacturers to actually implement measures for reliance and recognition of other organizations. We are also encouraging regulatory authorities to do joint monitoring, quality, safety, and the general vigilance of products. So we have activities which will be starting next year in which we will encourage the regulatory authorities to do joint surveys of their markets. And for those countries that have laboratories, we would encourage them to either get them certified on the basis of some international norms and standards. And finally, to development partners, as I mentioned earlier, is to support the activities of either WHO or the research in generating more information that could be relevant for regulatory purposes. So there's very little support, in our view, for the reproductive health products. So we have very few products in the pre-qualification pipeline, for example. And so, as I mentioned, only 2 of the 14 products are pre-qualified. There are organizations that are providing technical assistance to manufacturers of reproductive health products, but this has been going on for a very long time. So we need the manufacturers to be assisted in that respect. We need also support from those countries that have decided to harmonize or do work sharing for them to actually get support to do this work together so that they have the same quality expectations from the products. Finally, local production is one way in which we can achieve sustainability of availability of the product and also the quality of the product. So there is need to support initiatives on local production. Of course, there's local production, but sometimes it might be difficult to meet the quality requirements, or the market might not be big enough. So we need also to assist those producing countries. And it was deliberate on one of my slides to mention India and China because they are the major sources of generic products. So we need to support those countries that are producing the majority of the products to be able to have adequate oversight. So let's have better controls or regulatory oversight at source so that when the product gets to the market, they're already of assured quality. We need to worry only about the distribution channel. So on our website, we have the link to the studies that we have conducted over time, particularly the one that I was mentioning on the reproductive health commodities for the UN Commission on Life-Saving Commodities. Thank you.
Thank you very much. We have some minutes for questions.
My name is Vic Fabrato. I work for the National Center for Health at University. Thank you very much for this most interesting presentation. I think it's a great study. Be it one with quite some worrying results. And I was wondering, I suppose the feedback has been given to the countries that have participated, among other stakeholders in the study. And I was wondering, did the study provoke debate in these countries? Do you expect that there will be measures taken based on these studies? And is WHO going to make efforts to facilitate this process?
Are there any other questions? Or otherwise, oh, okay.
Thank you, guys. My name is Adventini. I'm here for Change Campaign for Sexual Health and Women Equality non-by because University Center for Development Corporation. My question is, you mentioned that a lot of products contain less oxytocin than mentioned or than the women thought they were taking. Is there a direct impact then? What are the consequences of this percentage? Do you have also data following up on that aspect of it? Thank you.
I'm not sure if it's a question is Reproductive from ITN. I'm not sure it's a question which is only relevant to this field. It's more general. But I was very interested in your comments about the possibility to shop around for the easier pharmacopoeia to some extent. As for me, the question is there any call or initiative for harmonization of pharmacopoeia's requirement? Is there still really a need to invest on national pharmacopoeias? I'm thinking of the Italian one to talk of my own native country. What's the added value of having such a plethora of pharmacopoeia, which is expensive and which at the end of the day doesn't help really to supervise and to monitor quality?
Thank you for the questions. With regards to the first question, yes, there was feedback given to the countries. So normally when we do these studies, we involve the countries in the planning or the development of the protocol, the review of the results, and also recommendations on how they are going to proceed after that. So all the countries were involved, the 10 countries. And we are actually following up within the WHO system. However, there's a downside to it, and it was mentioned also by Brian in his presentation. The Commission wound up in 2016, and this project was actually funded under that Commission. So effectively, very little has happened since the end of that study. We are continuing to work with the countries, but on a general level with regards to all products, not on reproductive health. So the focus on reproductive health has actually been diluted in us looking at everything in general. So there is need for support in following up on the quality of reproductive health. In WHO at the moment, we only have funding for pre-qualification of reproductive health. We do not have funding which is specifically targeted for quality monitoring of reproductive health products. So it is a bit difficult for us to actually use donor funding for other activities. So if we could actually get funding for conducting quality surveys, it would actually make our life much easier for these countries actually to continue with the quality monitoring of products. With regards to the oxytocin levels and impact, I'm not very well qualified to actually discuss the issue of the impact, but I can only postulate. Oxytocin, sometimes you are supposed to inject a certain amount of oxytocin, and if you don't see any effect, you inject another vial, or when it's sent international units, it's not working. There are no contractions, you give another 10 and so forth. So you keep giving the oxytocin and sometimes it's not working. So the impact could be that you assume you are giving 10 but you're only giving half. And you give more and more and more of the injection, and because it could have impurities or difference, you don't know what the impurities could be doing. So yes, it could have organizations around the world could be able to provide more insight into that. The other issue was with regards to the pharmacopoeia harmonization. This has been tried over a long time, and still efforts. At least now there's a coalition of pharmacopoeia to come up with standards in which they will work, how they come up with their requirements. But in terms of harmonization and having, for example, a few or a single pharmacopoeia, my impression is that this is not going to be in our lifetime. Mostly because for some of the pharmacopoeia actually it's a business. If you have a pharmacopoeia and you publish a pharmacopoeia, some of the standards, if you are going to test for impurities, if you are going to test for assay of the active ingredient, you need to generate a reference standard. And you can only use the reference standard that is produced by that pharmacopoeia. So there is a business aspect to that and some of the pharmacopoeias could actually lose business if we have one harmonized pharmacopoeia. And also, some of the pharmacopoeia are steeped in legislation, so having recognizing certain pharmacopoeia means that you might need to change the legislation in your country. So it's difficult, but work in progress slowly.
Thank you. I think there was one or some other question.
I have a question about the preservatives that you found. Did you identify what the preservatives were, and were they different than the innovator medicine? And introducing myself, I'm Betty Hindu from MSD for Mothers.
The preservative of concern in nearly all the products that we looked at was chlorobutanol, and it is the same preservative that is used by the manufacturer, the innovator. So it is the same. Well, chlorophenol, yes. So the issue is there could be differences in which the manufacturer of the innovator product actually manufactures the product. Some manufacturers actually added excipients to it. So they will have the same preservative but add other things to the product. We understand from other studies, UNFPA can attest to this, that the issue is that the preservatives actually change the pH of the formulation. And when there's a change in pH making it more acidic, it increases the instability of the oxytocin. So if you remove the specific preservative or maybe change to another preservative or add something else that can actually modify the pH or as a buffer, then it could actually make the formulation better. So there are formulation issues which maybe the innovator has addressed with the generic manufacturers, but yet it has been identified.
Yeah, I have another question.
That's also from DGD. You said that there were fields of interest that you couldn't do because you didn't receive enough funding of donors. But for donors at Belgium who give funding to WHO, it's not for us to define how you use the money we send. It's for your service or your department to set it up and to define it. So it's not the problem of the donor, it's the problem of WHO, I think. And in that field, could you a bit explain how the tendency is the last years of the percentage that is given by the governing bodies of WHO to the qualification for, let's say, the 5 last years or something like that? Thank you.
When you started your question, I thought I was going to be in a tight position not to be able to answer, but the last part makes it very easy for me. There has been no funding for pre-qualification from the core funding of WHO. So the pre-qualification relies solely on two donors, which is Unit Aid and the Gates Foundation. So there is no money which is coming from the member states to support the activities of pre-qualification. And of course, when funding comes to WHO for the core functions, it is diluted by other priorities. So maybe I do appreciate that it could be WHO which needs to look at this more clearly. But to a certain extent, maybe I would put it back to you to suggest that you should also encourage us to look at maybe the reproductive health area as well, particularly the quality of the products. Because we are a small team within the WHO, and there are other priorities. And already, because we have more than $14 million in pre-qualification per year, it is not considered to be lacking in funding in WHO. But unfortunately, because of that, and the $2 that we are talking about do not support reproductive health already. So yes, there is funding in pre-qualification, but it is not targeted for reproductive health. And WHO, because it's not getting a lot of funding, this is what I understand, we have put the money to other priorities. But I do take the point. I was just going to ask, sorry, Jason Bauer from my Research International. I was just going to ask if there was a link between products that were labelled with storage conditions up to room temperature conditions and those that were returning non-compliant results. No, there was no link to. So some of the products that failed when we did the testing were actually stored in the fridge. They were actually stored under appropriate conditions. So there was, according to the study, there was no bias towards whether the products were stored in the fridge or outside the fridge. This is why we suspect that it is actually formulation or manufacturing issue. Small question. My name is Stefan Basrara. I work for Belgian Development Agency. And so you studied very nice. The way I understood it, you studied central stores in a set of countries. Now, we do work more and more in fragile settings. And we observe that more and more products are coming into the countries in parallel ways. So do you have any information on quality of products coming into countries through these parallel circuits? Because it's alarming the way you present certain things. And I think you studied the best segments of the products available in a lot of countries. So have you any comment on that? I can only comment with regard to other products which are outside the reproductive health setting, because that's where we have a little bit more evidence with regards to the lower levels disease, not only at the central stores. But for us, the concern is we expected the central levels to have the best quality products. And therefore, it can only go worse as you go down. So the results are actually worrying at the central levels. So what about the lower levels where, yes, you have the parallel markets? We've done studies in other products, and as I mentioned, one of the different ways is the procurement agencies do not have the same quality assurance requirements. You have intra-agency organizations, intra-agency quality assurance programs that are run, UNICEF, UNFP, and so forth. They have guidelines on how quality should be assured as to the products that they are producing or supplying. But when you go to the countries, things happen differently. You have some instances where the regulators are ignored, permission to import is provided by the Ministry of Health or some other organizations, donations actually, where the country is in a very bad situation, and therefore you need to approve the availability of the product. So what we have been saying is maybe we should go up to the donor level, where the donor should actually assure the quality by having certain quality assurance procedures in place or policies that you have in place so that you can assure the products that are being donated. Because some countries are actually being, for lack of a better word, untwisted to receive the donations because they're in a dire situation. But what we are saying is let the donors come in with quality assurance backing for their products.
question, and after we can have a break and come back at 11 something. Okay?
Not on your presentation, but I know that there has been a study on misoprostol, which appeared in the Lancet Commission report on cancer medicine. It showed very much more problems, even going down to 0% content. Is there any plans to study misoprostol, or can you confirm or comment? Because it's not too bad if we, as a clinician, we get 2 of these samples, should have worked according to the specification. Misoprostol was really disaster. We always have a list of products that we would like to target for monitoring. And yes, misoprostol is one of the list. We are also gathering some information as to what could be the likely causes of misoprostol instability within pre-qualification, and we understand that it is a formulation issue. And that is being addressed at least in WHO and in the pharmacopoeia by actually insisting that the active ingredient is actually not supplied as pure misoprostol, but is actually involved with another ingredient that is added to and also the formulation. So we believe that it could be a formulation issue, but going forward, we would, it is on the list, but as soon as there is funding, we will be able to target it specifically, go out there to participate.
Thank you very much. It's now time for coffee break, and we meet at 11.
Okay, let's start again. For the second session of this morning, as you know, this seminar is being organized by 2 working groups of People's Health. This is the working group on access to quality medicines and the working group on sexual and reproductive health and rights. And that's the reason why we are sharing this session with you. This is my colleague Raffaella Rabinetti from the working group on access to quality medicines, and myself from the working group on sexual and reproductive health and rights. So in this second part, we have 4 best practices or experiences from the field, one might say, regarding availability, quality, and access to reproductive health medicines. We first start with Van Light of UNFPA, then we have Betty Hammer from MSD for others, and then we have Jason Bauer from Mary Stokes International. And then we had originally foreseen to have someone from a Belgian NGO, MDM, but unfortunately we had to cancel last minute, and we are very grateful that a colleague of ours from the NGO Melissa, Luis Fontella, was available for giving a short record on her experiences in the field with the NGO. So actually we have 4 speeches for this second part of the morning. So let's start with Van Light of UNFPA Supplies. May I ask the speakers for this part to introduce themselves briefly before starting their presentation? Thanks. The floor is yours.
Thanks a lot, good. So my name is Ben Light. I am the Senior Policy Advisor for Family Planning and Reproductive Health Commodity Security. I'm part of the Commodity Security Branch, which is part of the Technical Division of UNFPA. But since March of this year, I've been based in the Brussels Liaison Office of UNFPA. So I am based about 500 metres up the road. It's a real pleasure to be here. I've worked on what we used to mostly call reproductive health commodity security and family planning for UNFPA, within UNFPA since 2004. And in that time, the principal focus of my work has been policy and strategy development. And one of the things that has involved most recently is the iteration of this work, which is called UNFPA Supplies. So that's what I've been doing overview of UNFPA supplies because, as cited in the invitation, it is, it fits as a good practice. I think we'll see the extent to which that's true, and the extent to which there's more that we can do as within UNFPA as a community. I will then try and hone in on the specific issues of affordability, quality, and availability. And I wanted to underline from the start that obviously the framework within which all of this work is happening in the field and from within UNFPA is very much enshrined within a rights-based approach, that availability of contraception is an initial step. There are many other things required for an individual to be able to make an informed choice, free of any coercion, to decide to use modern contraception in order to be able to exercise that right to decide when, whether, and if so, how often to have children. Over the rights-based approach, obviously we need to make sure that we're looking at things through the public health lens and the health economics lens. There are issues of returns on investment. We need to generate funds in order to do this work, and that is, as we'll see and as we've heard, an ongoing and pretty acute challenge. Then I've got a good few slides. I'm going to try and ask the odd question. One of the key underpinnings of this work from the beginning, since I became involved in 2004, was related to a development adage that some of you are likely to know. Can somebody complete the adage? Give someone a fish and they'll eat today. Can somebody complete the rest of it? Okay, so we all know it. This is, if you like, the heart of what we try and do in development. We're trying to make the supplies available, but we're also trying to build capacity in country so that that country in question over time can do it without recourse to this external support. There's a couple of questions that touched on that. The gentleman at the end who asked the question about the German manufacturer, are we building a market for the German manufacturer, or are we looking at how we can really key into development processes in country? And I'm not sure that I'm going to answer that directly, but hopefully we'll touch on it, and if there are questions, I'll be happy to come back for it. So this work has got two principal focuses. Make sure that there are quality supplies available for people to use, and make sure that over time national capacity is built to take charge of all of these issues in country. One of the things that's very clear is these funds have never had and never will have sufficient funds to meet all country needs, which of course, from a humanitarian point of view, is maybe not a good thing. From a development point of view, it is a good thing, but it creates a lot of challenges of how you transition away from reliance on external sources of support to that transition to governments really stepping up and allocating funds themselves. And this, again, is a key part of my work, looking at how we can support that transition to increased use of domestic resources. So if we can go to the first slide. Some of these slides are a little bit busy, so I'm going to leave this information. If there's anything in any of these slides that's of any interest to any of you, as I said, I work about 500 meters up the road. If anybody wants a one-to-one, any kind of follow-up on any of this, I'll be very happy to give it to you. The first block, if you like, is perhaps the most important block of all of this work. The focus of this work, and this was enshrined in the original document that I was responsible for putting together in 2004, was that this should be a country-led and country-driven approach. In 2006, some of you remember, there was the Paris Declaration on Aid Effectiveness, and the guiding principles of the program as defined in 2006 were these blocks of country ownership. So country-led, country-driven, very much multi-sectoral, right-based, certainly with a value for money focus, but reconciled to make sure that there's a strong focus on equity, a strong focus on trying to reach the most disadvantaged, and reaching the most disadvantaged is a difficult thing to do when you're doing it through an equity lens, because they're the most difficult and therefore the most costly people to reach. It's relatively easier to provide quality services in big population centres, but it's more difficult to reach people in remote areas, part of the challenge. So one of the things that we've been engaged in the last couple of years is the heightened sort of optimization and leveraging of what this fund can do. This fund is not going to meet all needs, but how can we get this issue on the agenda so that governments and in-country stakeholders start seeing it as an issue that they have to take ownership of, rather than relying on external support from a number of dedicated sources of support. Typically, that has included UNFPA, UNFPA Supplies Program, and support from USA. So there has been this refocusing, if you like, and a stronger differentiation of what the program will be doing, to really make sure that we are bringing attention to those countries where the needs are greatest. And part of that involves differentiation among countries. And just to back up a little bit, this work is principally targeting 46 countries, and those are 46 of the objectively most needy countries in the world. So we're trying to identify those countries that are relatively more advanced so that they can, over time, transition away from this support. So the funds are flexible, it's transparent, systematic support, and the idea is that all of this work should, rather than being kind of verticalized as this one discrete package of support, it should be absolutely aligned with other things going on in a given national environment to harness the demographic dividends, to align with the cost of implementation plans of FP 2020, to link into GFF investments in this area as well, to make sure that family planning is covered within those different investments. Raising the profile of family planning, and doing that by, if you like, trying to show the way somewhat. So in relatively more advanced countries, the idea is that we, over time, will be able to phase out support as domestic resources are allocated, domestic efforts are harnessed in order to meet the family planning needs within country funding. So to give you a bit of detail on the next slide, we have differentiated the 46 countries into 3 groups of countries. Countries that are expected to require support into the medium term and probably beyond. Countries that are perhaps not ready to transition away from this funding support, but are in a more advanced phase. And then countries that are relatively among those that are better off. The countries that are described as category C countries that are approaching sustainability, there is a review to look at which countries they should be. And before we go to the next slide, which is a list of the different countries, a couple of notes of caution. This is something that we are, if you like, it's something of a proof of concept. How can you help countries move towards transitioning away from these domestic sources of funding? We're not rolling out this approach uniformly in the category C countries. There's some of the countries that quite simply are not really ready yet. There are some countries that definitely need a bit of a nudge, but in quite a lot of cases, those countries that are perhaps a little bit better able to step up and put resources in themselves are certainly happy to continue to enjoy a little bit of donor largesse in this area, although when you talk to the relevant priorities at national and sub-national level. They'll say, we've kind of got the funds, but it's great that you're paying for this. So it's a difficult process, changing the paradigm from provision of support to really saying, we're going to be scaling back, and that's part of the challenge we're focusing on. So on the next slide, hopefully you can't read this terribly well, but you will get this printout. One of the countries that, if you like, best symbolizes a country that really is in a position to step up and allocate own resources to meet their contraception needs is Kenya. And Kenya is also a country where we, as a community, UNFPA, USAID, the Supplies Coalition, as a brokering partner in this area, we are very often asked for additional support. Indeed, on my desk this week, there is a request for additional support from Kenya. You talk to the Kenyan authorities, they say, we've got the money and we can do it. You talk to the county level authorities in lots of the counties in southern and eastern Kenya, which are relatively more advanced, they'll say, we've got the money, we can do it. So it's really a challenge, and it really is a challenge that cuts the heart of the development process that we, as community, UNFPA, as a partner within this, are trying to affect, but it's not straightforward. Moving on to the next slide. I'm not going to go into lots of details about this. This is just about how there's been this revitalization process for the UNFPA Supplies Program. It was rebranded in 2013, I think. I think one of the problems is, because it's called UNFPA Supplies, people think it's all about supplies. The idea originally was that supplies was meant to be a noun and a verb, but it's only used as a noun. The idea was it would be UNFPA Supplies Sustainable Approaches, UNFPA Supplies Hope to Women and Girls, but it's really been stuck on the here's a condom, here's a verb, is a pill. These are some of the blocks of what the program is focusing on. Some of the things actually that Brian touched on, the CSP initiative, is to look at what is happening within the supply. What is the situation with the supply of contraceptives across a series of methods in country now? So when can we expect there will be a stock out if action isn't taken? So we've got that. That also links to another mechanism, which again is part of the Supplies Coalition infrastructure, if you like, which is looking about when a stock out has already taken place, how can the community come together to plug that gap, to make sure that supplies get to where they need to be. So block 2 mentioned here is this whole process of stepping up with supply chain management. I can't remember who had made the comment at the end of the last session about the extent to which UNFPA is able to track the products that are in a market. The answer is with great difficulty, and it's also something that we struggle to do with the products that we donate to that market as well. I imagine that the majority of us, if not pretty much everybody, has been to Sub-Saharan Africa, has been within these challenging environments, and they know some of the challenges that exist around supplies. Supplies also, of course, are subject to the possibility that somebody can take and sell them on to somebody else, etc. So we've got poor visibility, but we're getting better visibility, and we can talk about it a little bit later. Key building block of this work overall is block 3, enabling a more enabled environment for family planning. A couple of things specifically there, thinking about how we can encourage more in-country allocation of funds to meet one's family planning needs. If there's a health insurance mechanism in country, very often in the early stages of a health insurance and the essential practice services. Also looking at, and again I think Brian touched on this in his presentation, more equitable access to services using things like total market thinking. So where an individual, a group of individuals are better able to meet some of the costs, that they should be encouraged to do so, so that the central coffers and public health allocations can be focused on those pockets of the population that objectively have no means to make a contribution to those services, etc. I don't have a great deal of time. I've got quite a bit more to get on with, so I think I'll move on to the next slide. This is to give you an overview, hopefully quite specifically, of what UNFPA Supplies as a program is contributing to this global effort. FP 2020, I suspect most of you have heard of, and some of you will know in great detail, but FP 2020 is, if you like, the most recent global iteration of an attempt to build a focus of how we can do more to ensure we move towards universal access to family planning as part of universal access to SRH more broadly. And the goal is, as set in London in 2012, to give access to an additional 120 million women to open contraception. And it's very much within this context that this work is aligned and exists. So UNFPA today is the largest dedicated fund overall, the largest UN fund. And this work since 2004 has generated, and it's probably a little over 1.1, moving up to about $1.2 billion in that period. UNFPA is the principal global procurer of donated contraceptives, and it's estimated that about 40% of that global contraceptive procurement is coming from UNFPA, with the vast majority of that coming from UNFPA Supplies Program. UNFPA and UNFPA Supplies is certainly a principal actor in moving towards the achievement of the FP 2020 goals, but we will here see evidence that we are far short of where we as a community were hoping to be by this mid-stage, or even beyond the mid-stage, 2012 to 2020. And the UNFPA Supplies Program is supplying about a third of the users of modern contraception in the FP 2020 69 countries. We're also a major supporter of international NGOs that are providing family planning services, and it's estimated that about 80% of the contraceptives provided by MSI, Marital International, the organisation that Jason works for, are provided, 80% of those donated products are channeled through MSI in sub-Saharan Africa. So just have an idea of what it's estimated that the contribution of UNFPA Supplies and its predecessors has led to is in the region of averting about 63 million unintended pregnancies, about 1.1 million maternal and newborn deaths, and about 19 million unsafe abortions. And also, it's estimated that these contraceptives and their provision and use have the potential to save families and countries in the region of $3 billion in direct health costs. This is direct health costs rather than the broader social and economic costs involved. So when we talk about good practices, why are these good practices? All of this work is designed to improve the ability of the individual to exercise that right to decide when, whether, and how often to children. So moving on to goal level progress, and this is just some concrete data. This is the most recent consolidated annual data we have from last year, and just again, you'll have the information in the printout if you're interested. I'm just going to focus on three things: unmet need, concept of prevalence rate, and then this issue of the additional users towards the FP 2020 goal. The unmet need has been falling, which is of course what we want, but it's been falling more slowly than planned, as demonstrated in the graph. It's coming down at about 0.8 percentage points per year across the average of these 46 countries. And these 46 countries, predominantly in sub-Saharan Africa, are categorically the most disadvantaged areas, countries in the world. Unmet need, actually, perversely, often doesn't come down, it goes up as individuals understand the possibility that they could have more control over their fertility. So unmet need, actually, it doesn't necessarily mean it's a bad thing if unmet need's not coming down that quickly. It means that more people are thinking, actually, maybe I'd like to increase control over my fertility a little bit better. I'd like to use more contraception prior to actually going to use the service. So the key thing that's really demonstrating the extent to which this work is making a positive contribution, if you like, would be looking at the contraceptive prevalence rate, and that is ticking gently up. Again, in these 46 countries, it's ticking up by about 0.7 percentage points per year. But to put that in a broader context, again, back to FP 2020 and the additional users, the goal of 120 million additional users by 2020, again, as demonstrated in this table, it was hoped that by the end of 2016, as part of this effort, there would have been an additional 52 million users by the end of 2016. By the end of 2016, there were not 52 as planned, there were 30.6 million additional users. And that's in all 69 FP 2020 countries. And that includes lots of the very big population countries in Asia and East Asia and South Asia, where UNFPA supplies is not active. So UNFPA supplies is active in 46 of the 69 countries, but in countries that cover about 30% of the population of those 69 countries. And the UNFPA supplies country contribution to that 30.6 million is 14.2 million. So UNFPA supplies countries are contributing about 46% of the additional users per movement to the goal of FP 2020. I'm not sure if I explained that perfectly. Hopefully some of you got it. Again, the information's there. What can we say about that? This is not something that UNFPA is doing. This is something that UNFPA is a key facilitator of in a given country. We are doing this with the Ministry of Health predominantly, the public health partners predominantly, and very importantly, key international non-government organizations. MSI actually being the key partner, but also including PSI, IPPF, to a lesser extent DKT, and some others, but at a lower level of magnitude. So this is, I've just been told that time's up. I was just getting started. My apologies. So this is an important contribution, and in these environments, there are some good foundations to do more. Given that time is up, you can go on to the next slide. I'll just sort of go through these quickly. This is information you've got that I'll be leaving behind. So, as I've said, the modern concepts prevalence rate is going up, unmet needs coming down. To be a bit more specific, on average, at least 85% of service delivery points are offering at least 3 contraceptive methods. And that's actually similar urban and rural. And 50% of service delivery points are reporting no stock outs.
higher level of stockouts at primary care levels, and there are fewer stockouts in tertiary and secondary tertiary levels, which again is what we would expect. I'll leave the rest of the information there and move on to the next slide, if I may. Thanks, Tim. So I think this follows very much on from Regenda's presentation. This is some very specific thing about quality and what UNFPA has been engaged, particularly with WHO and a key technical partner, to do to ensure that we have got a bigger pool of quality products to draw from. So far as focusing on availability in terms of quality of medicines and quality of supplies, what do we have? Again, that information I'm going to leave with you, so I'm not going to go into it. But what we can say is that 10 years ago, we had, in terms of quality assured products, we had 8 products, and they were all made by innovative brands, quote unquote, big pharma. And there were 8 in 2011. Today, we have, I think it's about 30. And these predominantly, 2/3 of them are by manufacturing of generic products. So we've made a lot of progress. UNFPA has started procuring generic products, but what we procure is what governments ask us to procure. So we don't tell them what we're going to do. We ask them what they want, and this process of encouraging governments to start moving towards generics is an ongoing process, although a lot of progress has been made. An affordability overview on the next page. The prices, this is overall UNFPA's procurement services, what's available. The prices of about 94% of contraceptives that were procured in 2016 have come, prices of 94% of them are less, have been reduced. That's because of long-term agreements, that's because of volume guarantee mechanisms. The quality assured generic contraceptives over the last 3 years, UNFPA, by procuring more of them, has saved about $1.6 million. Just moving on to the final slide in terms of a couple of challenges. The key challenge we've got is that UNFPA supplies per se has got vastly fewer funds that are required to even meet the FP 2020 goals, and not even the FP 2020 goals overall, but that proportion of the goals that UNFPA is currently meeting. So to be on trend, we have got a cumulative shortfall between now and 2020 of $700 million. I hope it's been demonstrated that although this isn't perfect, this is making a positive contribution, and we've got a real crisis because we've got vastly fewer funds, and there is very significant and real scope for slippage of the progress that's been made because we don't have the funds. One of the other things, just going back to the issue of quality, is we now have quality supplies, but we're not procuring them enough. There are challenges around registration, what's actually available in country. And then one final note about affordability is affordability really in the past has focused a little bit on affordability for donors, affordability for organizations such as UNFPA to access these supplies. But as global level funding is reduced, the affordability issue really shifts down to individuals. And a report that came out last month, again cited by Brian last year, cited by Brian about the commodity gap and this analysis of need, is that already last year, 54% of all services are paid for out of pocket by individuals in sub-Saharan Africa. So we have real challenges, but I do think we've got a good foundation on which to build, but it does need funding. Thank you.
Thanks, Ben, and sorry for being strict on time, but we have some delays, so we have to be strict and free. Also for the next speaker, so the next
Great, thank you. So we heard this morning, Brian talked about Yexina, the supply chain in Senegal. I'm going to be speaking about the last mile portion of the supply chain. So question, can you hear me in the back without the microphone? It's good, okay, and if there's a problem, just if my voice drops, just raise your hand. Okay, so, you know, we've talked some about maternal mortality. Every 2 minutes, a woman dies from complications due to pregnancy or childbirth. So in the next 20 minutes, which I'll be speaking and answering questions, 10 women will die. So MSD for Mothers is focused on preventing women from dying in childbirth. And the way we do that is through improving the quality of care that women receive, as well as providing them access to contraceptives. Nearly 1/3 of maternal deaths can be prevented if women are able to plan and space their births adequately. So through a partnership that included the government of Senegal, Senegal's National Pharmacy, IntraHealth International, the Bill and Melinda Gates Foundation, and MSD for Mothers, we worked together to transform Senegal's supply chain. So basically, Senegal had one of the lowest modern contraceptive prevalence rates in the world at 12%. And nearly 1 out of 3 women did not want to get pregnant, but they were not using modern contraceptives. And one of the reasons was this, really the lack of access of contraceptives in the country. In a study that was done in the Dakar region of Senegal, 43% of the time, injectables were not in stock in the facilities that were sampled, and implants were not in stock 83% of the time. In another study that was done in public health urban facilities, they found greater than 50% stock-out rates for combined pills, for emergency contraceptives, for progesterone-only pills as well. And so really, we wanted to look at the overall supply chain. So basically, this group came together to, based on a request actually from the government of Senegal. So they made a request for some help. So this is the former contraceptive supply chain that was in place back in 2011 when this data was collected. And basically, there was one national warehouse in the city of Dakar, which sits on a peninsula out in the very western tip of Africa. And they were distributed from that one national warehouse down into 14 regions. And then the district had to drive to the regional warehouses to pick up those commodities, bring them to a district warehouse. Health facility staff then had to get on their bike or their motorcycle or their taxi and drive to the district center and pick up what they needed to have in their health facility. In addition, there was a paper-based system, and often data didn't flow, and it remained stuck at supply chain nodes. And then as far as finances go, these health facilities had to put cash out at the time they went to the district to get the commodities, and sometimes they didn't have enough cash. So they would tend to prioritize high commodity products over high margin products over low margin products, or they would get smaller quantities than they really needed. So we found 3 types of bottlenecks in the system. We found that commodities were often stuck up at the national and the regional level and not making it down to the facilities. We found that data was stuck down at the health facility level and not flowing back up through the supply chain. And cash was a limiting commodity. It prevented these commodities getting to the communities that needed them. And overall, the system had a large reliance on healthcare workers. But often healthcare workers weren't trained to manage logistics, and they didn't have the time. They were focused on their patients. In addition, the system was complex because multiple commodities were handled in different ways. So you might have had different delivery schedules or pickup schedules, different personnel working, depending if it was HIV, TB, malaria, or other medicines. So the partners worked together to put in a last mile solution. At the same time, the government of Senegal was improving their upstream supply chain as well. And they went from a pickup mechanism at the region to direct deliveries. So the national P&A made deliveries down to the district warehouses. They call that Jegasi now, which means in Wolof, getting closer, because the products were actually getting closer to the facilities, but they weren't getting quite there. So this last mile solution has now been integrated into Senegal's supply chain, and the overall supply chain is called Yexina, which means in Wolof, I have arrived. Some of the changes, and we'll take a deeper look, but some of the changes with the this healthcare system or this last mile system was direct deliveries to health facilities, and then over time, a information system was put in place that collected the data during those deliveries and allowed that data to flow up to the National Ministry of Health and to districts and regions. And then in addition, there was a change in the finances. Facilities could get commodities without paying for them until after they were dispensed to patients. So let's take a little bit of a closer look. Basically, private logisticians, and actually, before I go through this, let me explain that when the pilot was done, it was done with a all-public model, and then it was done with a public-private model. And the government of Senegal actually selected the public-private model, which involved 3PLs because of its higher performance and its cost-effectiveness. And this is the model that was scaled up in the country. So in the public-private model, the logisticians, private logisticians, go to a health facility monthly, and they count the products that are on the shelf, and then enter that data into a tablet, which you can see in the photo. The tablet helps them calculate how much product to leave at the facility. Based on the most recent 3 months of consumption, the calculation is done. The logistician can talk to the nurse and make a change to that. Let's say if there's upcoming training, or they know it's the rainy season and they're not going to be able to get to the facility the next month, they can make adjustments. The logisticians then go to their truck and collect the packages of products and bring them into the facility, leaving them with health facility staff. The amount of product that's left in the health facility is entered into the tablet. In some districts in Senegal, there's islands and a lot of water, so the deliveries could be made by boat, or are made by boat in those places. And as far as payment, if a district employee comes along on the journey, they will collect payment for the commodities that have already been dispensed. If not, then the health facility has 1 month afterwards to make that payment. So we've talked about how Senegal transformed from a pull supply chain to an informed push supply chain, using the third-party logistics providers to make those direct deliveries, but also to collect the data out of the health facilities and make that available across the country. That can be used to inform programs for family planning. And then health facilities are paying post-consumption, which prevents cash being a restriction. This model resulted in 98% availability of all contraceptive methods in all 1,400 health facilities across Senegal, impacting a total of 3.2 million women. Based on the success of this model, the government of Senegal asked that it be expanded to include other health commodities and essential medicines prior to transitioning it to government ownership. And so it was scaled up to about 90 essential medicines. And it was done in various phases. In first, 33 products were delivered in 2 regions, and then scaled up to 50 products nationally, and then 90 products nationally. There's a plan to go beyond those 90, but there's insufficient quantities up at a national level right now to do further expansion. And then it's planned that in the future vaccines would be included in this model as well. Let's talk a little bit about sustainability. We know that programs, often very good programs are put in place, but if they're not sustained, they have limited impact. One of the things that MSD for Mothers brought to this program was a recommendation to redistribute margins from the sale of health commodities to pay for distribution and logistics. And based on the higher volumes and the availability of the medicines, more revenue was being generated. And so health facilities are able to contribute some of that margin for distribution and logistics without impacting their total revenue available to operate their facility. The government of Senegal put that in place recently based on advocacy that was done in communities. And so we're anticipating that that could cover about 70% of the cost of the entire supply chain, not just the last mile portion. In addition, HIV, TB, malaria products are being distributed down to the local level now, and those programs have started to pay 10% versus previously they were paying 5% for distribution and logistics. The government's also committed to budget line items if needed, and soliciting support from additional donors if there's a shortage. As you can imagine, as products are available, they actually now need more products in the supply chain, so they're looking to make sure they have funding to supply those medicines. So just over a month ago, the government of Senegal and the National Pharmacy took over the operation and the financing of the last mile portion of the supply chain, integrating it into the country's overall supply chain. And they're continuing, they have set up contracts with 3PL operators. They've taken over the database that includes all of the data that's collected, and they are have set up a monitoring unit within the National Pharmacy to sustain this program over time. So from the scale up of the initial pilot back in 2012 to today when the government of Senegal is operating and financing Yexinal, there has been a positive impact and improvement in the availability of essential medicines throughout the country, which can lead to really healthier communities. So we think that this model can be applied in other geographies and to other types of products. And some of the success factors listed here can also be applied in various settings. You know, as people who are involved in global public health and contraception, I think we all need to think about how our money is being spent. And we've heard a lot today about the funding gap for commodities, but we also need to make sure that the commodities we're funding are actually reaching the last mile or reaching the people who need them. And so I really think as donors, we need to insist that high-performing supply chains are being used. Senegal has really shown us what's possible, and donors need to demand that supply chains are high-performing and cost-effective. So thank you, and I will certainly be glad to answer any questions.
Thank you, Betty. Also for keeping strictly time. We won't take questions now. We will do it after all presentations.
Okay, and if I could just add that I did leave some brochures of a technical report that we recently published. There's an English version and a French version. Maybe somebody can hold it up if you have one. Okay, and if you, I brought a limited number of copies, but if you give me a card with your email address, I can email you the PDF or I can mail you a hard copy.
Thank you very much. So now the floor is for Jason Bauer from Canada.
Hi everyone. So I'm Jason Bauer from Reproductive International. We're one of the four big international NGOs focused on reproductive health that Ben mentioned earlier. And I work as the senior pharmaceutical advisor, kind of predominantly managing product quality assurance across the partnership, both at the global level and also supporting our country programs. I've been asked, thanks for the invite to talk. I've been asked to share some insights and good practice, and I hope we can say it's good practice, some of this. I won't talk too much about the challenges, but there's plenty of those as well. But at least some things to throw a bit of light on some of the bigger issues and also some of the in-practice stuff in the field. So as an organisation, our core focus is really on family planning and safe abortion, but we also do have other reproductive health services. But the way that we do that is we have centres, we have clinics in the 37 countries that we work in, we have outreach teams, we have single midwives who work as MS ladies, but we also work with the private sector and private clinics, do social franchising and support the providers to deliver family planning and safe abortion services there. And the other thing that's not mentioned here is something we've moved into more recently, which is public sector strengthening efforts. And so we working now with governments on a lot more on training and supervision and competency assessments and trying to support the public health system as well. And then finally, one additional thing which sets us out from humanitarian organisations that many of you will be more accustomed to, which is social marketing. And this is where we try to provide low-cost, affordable, but high-quality products available in private sectors and try to increase the access to those through distributing in pharmacies and drug sellers and in private clinics as well. And so the focus of that is largely on products that are used in those environments, and that means short-term family planning methods, emergency contraception, condoms, oral contraceptives, but also medical abortion drugs, such that more people can access affordable products there. Thanks. And just at the bottom there, we've got MySecure, which is one of our flagship products, I guess, so it's an MSI branded misoprostol product. So just an insight. Initially, there's lots of poor quality RH products. I think we've seen, Rutendo has obviously talked about this to some extent, but one thing that wasn't mentioned, but which was mentioned in discussion was misoprostol, and this is, I think this is the graph which is the study that we're referring to, which Concept Foundation and Peter Hall developed, and I think misoprostol wasn't included in the survey, if I'm right, because there was already this information on lots of sampling that's been done on misoprostol, and it's really a terrible picture in terms of quality. As you can see, lots of poor quality products with very low content of misoprostol are circulating in low and middle income countries. Effectively, all of the samples that have been taken of products with stringent approvals from WHO or from stringent regulatory authorities appear to be stable and good, but a lot of other products that don't meet those same standards will degrade in content, and that has really serious consequences. So this is a big issue for misoprostol. It's well documented now, and it's a really important factor. But then there's also a lot of other products out there, the general medicines. We've got a survey that was referred to here from WHO. This is a graph from the Indian National Drug Survey, where they looked at samples in public facilities and a couple of key products. And there, certainly for us, lignocaine is really important for us as well. But these are the kind of products that are often also present in the markets that we're working in. So it's definitely an issue. Pregnancy tests even. This is from Australia, where recently there was a lot of false negatives were being reported, and so the TGA did a review and subsequently ended up more than a third of the products on the market have since been withdrawn. So for diagnostics and devices, it's an issue as well. So just one quick remark here, and I think we see the standards of the national drug regulatory authorities are do appear to be improving, but then there still seems to be products coming onto those markets, even getting registered through those authorities that we know don't meet the same expectations that we would want. So it's still an issue, and I don't know if there's a lot more to talk about that, but we're certainly seeing competition from more products of lower quality, and that's a concern, and it makes providing access of those quality products more difficult because of the competition and the lower prices of those products. So kind of coming back into what we do internally, what we see is that obviously there's key products. We need to have more stringent standards for those products that are the most key to us as an organisation, and so that's really specified clearly in our policy on product quality. But in this table, I guess I articulate how we've kind of managed this. So we've got our TSRH products, those products that are really core to what we do, and for those we have quite stringent standards. Predominantly all of the I think all of the contraceptives and that we use are WHO pre-qualified or UNFPA ERP approved products, and then also the medicines that are used for safe abortion. But then there's also the devices, the equipment used for manual vacuum aspiration, which have to be obviously good quality, pregnancy tests, HIV tests, metal surgical instruments. So all these things we think are really important. We have fairly stringent standards, and we try to do as much to facilitate global procurement and supply of those products. But then you come into the next category, which has always been the difficult one, because there isn't necessarily WHO pre-qualified products for a lot of these, and that's the supporting medicines. And it's this real gap, and it's like, okay, we effectively have to do local procurement for most of these products. How can we do that in a way that actually makes sure that we're getting good quality, or at least better quality assured products, lower risk ones? And so we've implemented standards for that, and that's with support of Biomed organisation and using the resources that they provide to us. I'll mention that a little bit further in a moment. And then I'll skip on and come back to that in a sec. We've got a tool, an online tool where programs all have to specify what specific products for all of these TSRH products that they're actually using in their programs. And so it's kind of a monitoring tool, but it's also where we publish our lists of approved products, our list of approved manufacturers, our list of approved international wholesalers. So that's another initiative which we've introduced and which is going fairly well. So WHO pre-qualification program we're very supportive of, but it doesn't cover all products. As I mentioned, there's the ancillary medicines, which only some of which are covered there, and there's lots of different products on the market. But even for like the contraceptive products, it's the oral contraceptives, it's mostly limited to a couple of different types of medicines. If we're expanding to give a bit more choice to clients, then we're looking at products which aren't necessarily covered there. And there's a limited number of generic products that have actually been able to meet those standards. So it's still a challenge. So what we've done, as I mentioned, in terms of the ancillary supporting medicines, is that we use Pharmed system, and they've got a database of manufacturers which have approvals from like good manufacturing practice, approvals from more stringent regulatory bodies or stringent inspection bodies. We we use that list effectively to say these are the list of manufacturers that we recommend that you procure from. If you're going to procure locally, you need to procure it from these approved manufacturers. So that's effectively the pragmatic step that we've taken there. And then also we publish also, if you can procure internationally and import the medicines, which is usually difficult to do for us because we don't have the right to do it in most countries, we will get it from our approved international wholesalers, which are also assessed with QuireMed as well. But QuireMed also facilitated supporting us to develop a risk management approach for assessing some of the higher risk products that we're most interested in, mysophosphor products, for example, and other products that aren't covered by pre-qualification, where we'll do our own quality assurance approach there. And so we do an assessment of manufacturer quality and we rate it. We do an assessment of the product dossier and we will rate that. We will look at the inherent product characteristics and risk assess how high risk is this product. And then we plot that out on a matrix, which we then use and we say, okay, does this meet a minimum standard? Or if it does meet our minimum standard, what level of quality assurance do we need to put in place in terms of quality control testing to manage the risk there? So another quick thing internally, I think something we found is that ownership of product quality is difficult in country programs. It often falls somewhere in a hole between the clinical people and the procurement teams who actually don't know much about the products. So we've really tried to develop clear accountabilities on that. We've stated effectively the accountability lies with the head clinical lead in each program, and they need to define the specifications of products in their team. They need to make sure that products procured are meeting the required standards, and then that's all supported, of course, by the procurement and logistics teams. And there's even a product committee which does a number of different steps, which then will report into their clinical committee as well. We've put together practical guides on all different aspects of selecting good quality products and then understanding quality assurance, recognizing the limited capacity that are in our programs. Obviously, we encourage them to employ pharmacists, people who can kind of sit in between those roles and manage this. But we've also integrated incident reporting, and so now we've got quite a strong pharmacovigilance system effectively because we've integrated in what we already had or what we were developing as quite a strong clinical incident management system. We've incorporated product-related incidents into that, and so we can get quality reports on issues there, and that's really been quite successful. And then I guess I'll just finish with, I'm mostly talking about quality assurance here because that's what I'm most involved in, but obviously this is also about access, and so just touching on a couple of things in that regard. Standardization of products is so important to having, it's really to be a precursor to having a solid supply chain, being able to have understanding of your needs, consumption, and so we've set this up in place in all country programs that each will have a standardized product list. Their providers will have a specific product list specific to their channel type, to what they do and the services they provide. And that means that we can shift from the paper-based systems as well to using, predefined templates for these are the products needed, this is what we need to do stock takes against and reorder and calculate consumption for. So I think that's been a really important step in terms of supply planning. But also part of this, you can see in the column, which you probably can't see from there on the right side, but we're also, for each of those products, programs need to say, okay, if it's a key SRH product or a key ancillary medicine, what are our approved products? And so they're identifying ahead of procurement that these are the products which we're actually going to buy from qualified manufacturers that meet the standards we need. And the clinical teams lead this, and they make sure all the specifications of products are really clear in these lists, so that that's just handed on to the procurement team, who can then easily procure accordingly. So just a couple of other measures to finish up to improve access, and we're certainly strengthening in terms of our supply planning, which is really critical. Everybody does annual supply plans now as part of their business planning, and then there's a quarterly stock status monitoring and effectively reviewing against the annual plans that will happen routinely, such that we're getting that better data visibility, because that's so critical to actually managing stock risks over suppliers and stock outs. Introduction of stock out indicators, and then of course donor engagement through the coalitions that we're a part of to try to increase, to address these funding gaps. But obviously working more and more closely with the Ministries of Health, which is really the future, and ensuring that, you know, we're communicating with them and working together, and our needs are considered in their needs for the entire country as well. So, so that's it. Thanks.
Thank you, Jason. Now we have Elise van Bellen of Melissa, who will share some insights on challenges and solutions with us from the perspective of field program implementing NGO.
Thank you. So my name is Elise van Bellen. I'm a public health doctor working with the medical NGO Melissa. I have no slides and no figures, but I'm excused because I was only asked this morning to contribute. But I don't think you will mind, because we've had a quite a heavy morning, so I'll try to share some of my experiences. I don't know if they will lead to solutions. But I've been working about 10 years in Africa before joining NIMISA 5 years ago, and now trying to follow up on health programs, mostly in Sub-Saharan Africa and West Africa. The focus of the work we do is on trying to strengthen peripheral health systems at a local level. So we work with the health facilities, the health centers, and the regional hospitals, the public system, and we work with the health staff. We try to reinforce so that primary health care is reinforced, with a focus on maternal mortality and maternal health, but no specific focus on family planning or reproductive health care. We really try to reinforce primary health care so that family system is reinforced. NIMISA has been a member of Because Health and of Quamet ever since it existed. We signed the Charter for Quality Medicine about 10 years ago, Tina, I don't know, a long time ago. And recently the declaration of commitment to quality assurance with the Belgian Development Corporation. I think Belgian actors are quite active and aware and trying to get together and trying to get into good practice. But the challenge remains. How are they to do it? As we try to strengthen local health systems, as a principle, we do not import medication. We try to strengthen local local supply system. So the national purchasing office and the distribution offices try to support them so that we can have a guarantee that there is pre-qualification in the medicines that are being bought and that are being distributed on the field. But the leverage is always limited. We don't import all medication, but we give money to the local distributing offices so that they can supply medication to the health district. One of the big problems is the core financing of those national supply agencies. The core financing or the working capital, it is too small. A lot of the big donors are still importing in a parallel way, are still importing their own medicines. They often place them. They ask them to then manage them, but that is not enough. There's a lot of parallel import. There's a lot of supplementation, and there's on the end of the field, there's a lack of availability of medicine. The quality, we say up to 25% is probably of that quality, but other figures will show it, and if you go to, depending on the context, I very often use the Congo as a reference. It's the one I know best, and it's in my experience, one of the most problematic ones. It's probably a lot more counterfeit medication and medication of dubious quality in those on all these places on the market. The mobile drug vendors, the pharmacists just putting up a stall on the road and putting stills on display. All the health workers that have private pharmacies on the side to have some for-profit business. Only looking at the tablets makes you wonder whether there's actually some active formalin in it. So I don't want to dramatize, but I think that we underestimate the problem of quality of the medicines on the field and the availability. Counting on disease control programs is problematic in both ways. There's too much and there's not enough, and we cannot use it. There's often too much and it's expiring. I visited only last week health centers in rural Mauritania. You find a lot of expired drugs, and very often it is because they have explicit orders, explicit instructions that they can only be used for this kind of patient, age-specific, disease-specific, whatever. So other patients needing the same medication, well, they cannot get it from this lot because this lot comes from this program with specific reporting instructions and etc. That's only one of the problems. A lot of other drugs are just not available. And it's a very complex environment. It's not just the fact that they're not available. Last year I think I was discussing with one of the doctors in Congo about family planning because it stays a very big issue. Memisa is also often associated with the Catholic Church, which I think is an important heritage and inspiration, but not at all, not at all an obstacle in the strategy on reproductive healthcare and maternal health. On the contrary, I think even the partners we work with, even if they originate from congregations or whatever, it doesn't necessarily change the professionality of the work. But there are a lot of other factors. I was discussing with a doctor in Congo on family planning, and he was actually convinced of what he said. He said, we don't need it, because we're talking about adolescents or young girls. In our culture, women do not have sex before marriage. Yes, and he believed it. So You have another problem there. It's even the doctors, the professionals who count on are like, convinced of certain beliefs. It's difficult to start working with these people and improve certain elements of health. Then there is this big problem, I think, that there is not a shortage of human resources for health. There's actually slowly a plateau. There's too many trained health workers. And I say trained because I think at the same moment the quality of the training is very problematic. Medical schools, nursing schools for nurses and doctors are just being created everywhere with very bad regulations, with very bad teaching probably. So you have universities, hundreds and hundreds, thousands of students in medical schools. There's no space. They don't have courses. There's they cannot possibly follow the lectures, whatever. There's an overproduction, and they're badly distributed between urban and rural settings, and that's the whole problem we know. But the problem is not only that there's not enough drugs available and that the quality is bad, but they actually don't really know how to use them. There's a lot of abuse of drugs because people don't have the experience anymore, don't get the right training. There's a lot of overuse. A lot of prescriptions have at least 2 antibiotics and an anti-malaria drug that's standard, and then you fill it up and so the problem is a lot more complex, I think, than availability and quality, and there's a lot of work to be done. But I would like to get back to the commitment of all trying, the whole donor community, all the different partners, of trying to reinforce local supply systems when we talk about provision of drugs. It is still not the case. We all talk about reinforcing local health systems, and we talk about capacity building and ownership, but on the field, this is not what we see, and I actually do not understand what is keeping us from taking up that engagement to all say, even if it doesn't work perfectly today, let's reinforce the national supply system, and let's make sure regulations are respected before we let's make sure regulation is impunity and lack of regulation makes it impossible to get quality medicine on the field. Even if we all strive to national supply systems and they're all pre-qualified and WHO is giving the green light, as long as there's parallel import of counterfeit medication and impunity because you use it in context where it's full of survival systems because people are just so poor. You are, how do you say it? I don't know in English. Trying to, it's a vicious circle. So I call to everybody to try and in the first place support national supply systems and work on reinforcing regulations and implement parallel markets. Thank you. Thank you, because people now will hardly believe that we are here to talk this morning because this looks very well prepared, and thanks because you put new issues on the table. So we started our second section with 15 minutes delay, so I think it's fair that we take 15 more minutes now for the debate. We have some 20-25 minutes. I would ask people who have questions to raise their hands. Please introduce yourself, and also possibly if you have, if you want to pose the question to a specific panelist, also please chat it. Terence, I think you're the first one. Yes, thank you. I'm Terence Denneau from the Institute of Tropical Medicine in Antwerp. Thank you all for the interesting presentations. It's really important to address these issues. And I have a question to Ben Lai, for Ben Lai regarding the supply chain that UNFPA is using now for clinical contraceptives to the field. I mean, it used to be a current system. So now is it still the same, or can you give, like, among the 46 countries that you were talking about this morning, the proportion of countries where the system, the existing system is used, or where there is a parallel system used instead in those countries? So to have an idea, because I'm coming back to Eddie's remark that, of course, it's not easy to use existing systems all the time, because it's not always functioning well, operating well, but yes, I know that UNFPA used to have a prior system to be more effective and to be sure that contraceptives were there. And so I just want to know what is the situation now in the 46 countries that you focus on. Then I think you can answer immediately. We all try to keep answering questions as synthetic as possible to give more room to everybody.
Thanks, Terence. I have to say, I am not aware that we have used the parallel supply system. The premise of this work, certainly since I've been involved, this is not to say that there's never been any exceptions, of course, but we always worked through what was recognized to be, and in many cases still is, a weak and imperfect system. But that by doing that, of course, the premise is that it gets stronger over time. There's certainly other partners that have had a more like a sort of humanitarian focused approach to just make sure this doesn't work, so we're going to do something else. I don't think it's controversial that I hear sites that this has been something of a policy that the USA has used in the past. They've moved away from that. I think the reality of the way services are contracted is sometimes that there's a very specific pressure from the funders to say, these are the results that we need. So there's often a pressure to verticalize things. But certainly in our policy documents that I've put together in the past, there was always an undertaking that we would work through the national systems and that we would advocate for moving towards unitary systems. It's not necessarily that even in an ideal system there would be one single integrated system for everything, but there could be moves towards something that's integrated. And that, to my knowledge, is certainly what we aim to do. Obviously in humanitarian environments there can be diversions from that norm, but certainly that's the approach. Thanks.
Any other questions, please?
Yeah, hi, my question is for Betty. Well, first of all, congratulations for the work on this project. Yes, now it really is one of the many successes that we can point to in the space of working in. I guess my question is about, I've always wondered, we've been talking about this project for a number of years, and I wonder, why aren't we doing this in other countries? Why aren't other countries already doing this? Is it because they're waiting to see the results, or is it because some other lack of initiative or something other? It's so obvious that this is a success, and it seems like it would work in other countries. I'd like to just hear a little bit about how other countries might approach this. What lessons could they learn from Senegal? I do know that there was an effort in Togo that really didn't go so well. Might be interesting to hear about why that was.
all like to know, because I think Senegal has had a lot of success, and I think, you know, there are elements that will be very successful in other countries, and the model can be applied. Yeah, some of the, one thing I would say is it was a big undertaking. It took a wide partnership, and it took many years. So it wasn't just something that happened over 6 months. It takes that long-term commitment. And I would say in any program, for any program to be successful, what's really key is government commitment to it. And we have very high leadership in Senegal, from the Minister of Health, you know, to throughout the Ministry of Health. So that certainly had a big impact. And then donors being able to come together. So we as MSD for Mothers are interested in where we can apply this model, and we're starting to plan some work in Nigeria at a state level. One of the criticisms we've heard is that, well, Senegal's a small country and it worked there, but it's not going to work somewhere else. So we're going for the big, the big one to see if we can impact Nigeria to bring elements of this to their supply chain. And we hope other donors will look for opportunity. And I can't really speak to Togo specifically. I don't know what some of the challenges were there. We know that really the setting up the implementation of this was key, and IntraHealth played a big role on the ground to put the system in place and to provide supportive supervision to both the 3PLs and the government. And I think that was also a big factor for success.
Thank you. Any other questions? Therese again?
Yes, sorry. I was wondering whether we knew very well about the quality of contraception, about the pills, but also, well, implants, I'm not sure to which extent now other manufacturers are on the market and are starting to sell implants, but I mean, do we have a good knowledge about the quality of contraception?
So, I mean, I can make some comments. I think maybe Linda might be more appropriate, but the large majority of contraceptives that are used in certainly in Africa would be either approved by stringent regulatory authorities, they're innovative products, or are otherwise WHO pre-qualified generic. So that's probably the large majority of contraceptives that circulate in Africa. It's a different story in Asia, where there's a lot more local manufacturing, Bangladesh, Pakistan, and Vietnam, and these places, and in India, of course. And so I think it could be a slightly different situation there in terms of quality. I'm not sure how well that's going to check. Yeah. Emergency contraceptive pills are another story, where there's like kind of become this, you know, there's more and more profligacy of there's more product going onto the partner markets there, and so a lot of those are not necessarily pre-qualified products, and that would be interesting to look into a study surveying quality of those products.
Then you did want to address, I think, just with regard to the implants, there are 2 innovative products, and there's 1 copy of one of those 2 innovative products that's being pre-qualified. So implants is relatively clear at the moment. So turn it for any other information. I think Jason's point about emergency contraception is very interesting, because emergency contraception is seeing massive variability. The Concept Foundation did a study, or somebody did a study a few years ago of emergency contraception in Peru, and they market that is slightly something of a bellwether for what else might be happening in the market, because as it commands a relatively high unit price, there's a lot of counterfeit and falsified EC on the market. So it's a particular issue, but it's also part of the market that has got relatively less donor funding going into it. So it's part of the market that is moving more towards the commercial model. The EC market in Kenya is highly diversified, very variable, but there's a lot of stuff there. And that's a little bit more like the more general observation about the broader range of quality that you get in the Asian markets and also in the Latin American markets. Thanks.
Thanks for that. Other questions? Then I'll give it my, sorry.
I have two questions. One for UNFPA. You showed a figure where the funds are diminishing since 2012, and you show it for all categories of products. Only I saw the implants a steady state, even within the years a bit increasing. Is it donor driven, or is it market linked in the partner countries? The second question, or actually I have three questions. The second is to MSI. Did you also to MSI? Did you also find the decreasing of funds since 2012? The peak in 2012 and then a decreasing, or is it only by in UNFPA that they saw it? And then a third, more general question to all is the sustainability versus distribution for free of the products. What is your opinion on the disturbing of the markets by distribution for free of the products? Thank you.
Thank you. Thanks very much. I think the peak probably of funding that we received in about 2013, just slightly later than the same. But yes, with regard to implants, there's what's called the Implant Access Initiative, which provided access, if certain volumes were made, would provide access to a price that was significantly below what was then the prevailing sort of commercial price. It brought the price down by about 50% for UNFPA, which already had the most favourable economic commercial arrangements. So it brought the price down to an accessible level, but that's been to the benefit of organisations like USAID, UNFPA, being the principal funders of providing donated products in the country. So certainly it has been this donor effort to make sure that there would be wider access to quality short implants, and they are the two innovator products, the one rod and the two rod implant products. Just briefly, as I've got the floor with regard to sustainability, and the issue you raise is absolutely key to what the donor community is talking about at the moment. We've got much more of a focus on not making sure the products are there, but particularly given the resources constrained, how we can encourage governments to allocate more funds and how we can tap into other sources of potential funding for family planning. I think the broader issue in many countries is, in a lot of these countries, more than half of all contraceptive services are being paid for out of pocket by individuals already. But we've got a big push in very strong alignment with USAID as the other principal supplier of donated products to select certain countries where we will be trying to have a lockstep approach with USAID, UNFPA, and others, certainly the core conveners of FP 2020, so the Gates Foundation, the World Bank is aligned to this, to be looking at how over time we can start scaling back this dedicated support from UNFPA and from USAID, again, in countries that are better able to meet the needs with their own allocations. So the idea would be looking at governments, encouraging them to allocate more funds for family planning or funds that they control. So that could also include GFF support, but also looking at how we could encourage individuals and in a more equitable way. So ensuring, as I mentioned briefly, that a broader range of contraceptives are included in health insurance schemes, and that people who, through their payments to those health or their contributions to whatever form they take, would be able to access family planning services without without having to make an out-of-pocket payment. And where there is an out-of-pocket payment, that should be done in such a way that there's better segmentation of the market, so that it's individuals who are better able to meet those costs, so that we can focus on getting the no-cost support and services to those who are not able to make contributions. Thanks.
Okay, we have the answer of Jason and then Rogenda, and then we move to the wrap-up.
I'll try and make it quick. I think as an organisation, the funding decrease in commodities through UNFPA has been a huge issue for us, and it's been a struggle as an organisation. That being said, at the same time, there has been an increase in general investment by USAID over that period of time, which enabled us to grow as an organisation to have a bigger impact, and other donors as well. And obviously that's a lot of that funding, a third of that funding is just getting chopped off, thanks to our new friend in the White House. But we're trying to operate as a sustainable organisation ourselves, and it's a social enterprise effectively. And so we have channels, our clinics that work on cost recovery and try to add small margins to things. We add small margins to products that we distribute through social marketing. We try to funnel that back into actually being able to be sustainable as an organisation. And also even our clinics in the UK and in Australia, any money that's made or any surplus we get from those operations goes into our international programs there. So what's affected though is our outreach programs, and those programs where we're really serving people who really need it and who otherwise aren't accessing it, where we provide free services, and that stuff is particularly at risk with these funding shortfalls. It makes it really hard to sustain that.
Rogenda?
I just wanted to contribute to the last question with regards to sustainability and contribute that we need to do more about advocacy on the quality of the products that we are supplying. I have two anecdotes, two countries where I visited, and I found that people were getting substandard oral contraceptives from pharmacies and on the street. And the main reason was that in the family planning clinics they're being provided for free or for 50 cents. So it was too cheap and therefore poor quality, and people went for other alternative sources which were of even worse quality. So we need to consider this when we're talking about sustainability of continuing to have this product available on the market.
Thank you very much. Now, I will have to give the floor to Tim for a wrap-up and to Catherine for take-home messages and the logistics of photo and of lunch. Before that, I would just ask the sixth speaker of the day to give us 3 words for a take-home message for the policymakers. So if you had to tell the policymakers, these are the 3 priorities, these are the 3 words, but it must be 3 words if you speak more than 20 seconds and we stop it. Rogenda, do you want to start?
Well, this is the start.
Jason?
There we go. Let's say quality policies from donors harmonized and a key focus from donors on quality.
Okay, great. Brian?
It's all about her.
Ben?
Quality costs, we need more money, countries need to step up.
Great. Leslie?
Demand, high quality, cost performing supply chain.
Very clear. Elise? I'll only repeat what I had agreed. So let's all join hands to reinforce national supply systems and regulation. Thanks a lot. Now it's up to Tim as a rapporteur to wrap up, and then Kathleen. So just let me something, sorry. On behalf of myself and my co-chair, it's a bit of publicity, but we have use of our role. I'm the chair of the Because Health Working Group of Medicines and the of the Because Health Working Group on Sexual Reproductive Health. If you wish to join one of these groups or to be copied to our mails, and then based on what we write to each other, you will decide whether to join us or not, please just approach us now or during the lunch break and give us your contacts, and you will be put on the distribution list, not only of Because Health in general, but of the specific working group. Tim, now it's ready for you.
Thank you. It's a great introduction of what we do as Because Health platform. So I'll be very, very brief because the policy recommendations by the panelists themselves cover already part of what we've heard this morning. Thank you all. Thank you, speakers. Also, thank you, large audience that participated and kept awake until late. So just before we go for lunch, we've heard many different insights and I think responded to the call by the Minister to bring in some specific recommendations. So if I, for one, we've heard on a number of recommendations from Rutendo on what can be done to improve the quality of products, of drugs. We've heard about the availability, the need to strengthen to start supply planning and monitoring. One of the things I've noted that quality is everybody's responsibility, but needs to be organized. On the availability, so we've heard from different speakers examples on supply chain and stock management. The example of moving towards a informed push chain that was provided based on what happens in Senegal. Importantly, I think we also touched upon the affordability. We ended with it, the last question by Indias. It was the example of using part of the margin that was mentioned in Senegal, but many of you have also reiterated the need for ODA, of a role for donors, and a careful transitioning to increase the domestic resources, but it can't happen overnight, and there might be a good reason to remain funding it internationally. We've had a reality check provided by Elise from MEMISA, and I think it's important to strengthen this, that we need to set up all the systems, but we need to go beyond what we know of what is working best. The national centers that know that if it's problematic at the national center, it's much worse if you go lower down the system, and even worse if you go to the street level, so to speak. So I think you'll all join us in the call that we will draft or rephrase in recommendations to further strengthen the national distribution. in that regard, I think there's many things that have been, many more things that have been said, many more good examples that have been raised. And so within the two working groups, some of these elements will be taken up further. In 2018, we will also look back on 10 years of a charter on quality of medicine. I believe Catherine might say more on that. But as the whole of the platform, we are keen to continue to work on this. Thank you.
Thank you very much. Well, just have to share with you two different messages very briefly, because I'm sure you still want to communicate. Well, the first one is that donor and implementing a key role to play to guarantee quality of pharmaceutical products in low and middle income countries and vascular and fragile settings where Belgium is currently playing and operating. Well, we have already created policy as mentioned by the minister in the morning, and we'll continue to work closely with the platform itself to facilitate the implementation of this commitment. And we'll work with the working group on access to quality medicine. And probably we'll do another event next year in 2018 with regard to quality. Well, we at DGD we will continue to work closely with the WHO qualification, and with the European Commission and the EU like-minded countries in order to enhance the critical mass of donors asking for quality. And also in order to raise awareness about the need to harmonize QA quality at EU level. And the second take-home message I have is more concretely for new programs from Belgium Development Corporation that are in the process to be done to be created in countries, in our partner countries, where there is in some countries strong focus on culture, and I think, for example, in for Benin, and where we can probably use the food school recommendations from this debate and from the seminar to build with the partner countries, with the Ministry of Health, but also with the community and with other players such as private sector in the country. And I also mentioned the good key role of regulation in this area and of integrated health system. Thank you very much for coming and for this fruitful debate. So I invite you for a photo here in this room. I think it's good to stay here to the back. And after there is a lunch provided in the cafeteria, and